So we have 32 attendees. Okay. Good evening, ladies and gentlemen. It is my pleasure to be with you today to moderate this nice lecture entitled The Updates in the Protocol of the Management of the COVID-19 Infection. This pandemic and the crisis now has affected all the countries all over the world. Some of the countries still under the effect of the first wave. Other countries have been past the second wave, but unfortunately now they entered the second wave. Some of them started to register and to have higher cases for the last few weeks. So our aim to present this lecture to show you the updates in the management. We will start with some action plan, then some medical protocols for the management of COVID-19. Then we'll see how to manage the ICU patient and the oxygen therapy, and we will end the lecture by very interesting and attractive lecture about the radiological imaging of the patient with COVID-19. First of all, I want to thank Dr. Ayman Al-Layla. He is a specialist health informatics. He is the most responsible for this lecture. He organized it, and he had a very hard work. Every day he's calling me to prepare for this lecture. And also I want to thank all the speakers. Dr. Ala, he's a consultant physician. He's the maestro of the management of the COVID-19 in our hospital. And Dr. Serinath is a consultant pulmonologist. He has the major role in management of the patient of COVID-19, mostly in the ICU patient, together with Dr. Ala. And also Dr. Osama Jalal, he is the consultant radiologist. Without him, we cannot diagnose the patient with COVID-19. He plays actually a very major role to help us to guide the management of this patient. Without further ado, also I want to thank my dear friend Dr. Wala Juburi. She played a major role in distributing the invitation to all our colleagues in Iraq. So, dear colleagues, let me start to invite Dr. Ayman Al-Layla. As I told you, he's a health informatics specialist. He will show us some slides on action plan, how to improve the health system in Mosul City. Please, Dr. Ayman, start. I will make you host.
Thank you so much, Dr.Thair. Jazakallah khair. Allah yahfadak. Sorry, Dr. Sernath, that would be a quick and in Arabic. I will try to show our colleagues what is going on and how we can do a crisis plan specifically for Mosul. السلام عليكم اخواني اهلي في الموصل، الساده والسيدات والساده الاعزاء الحضور. ربي يحفظكم ويجعلها ان شاء الله امسيه مليئه بالمعلومات المفيده والنافعه. نحاول نقدم فيها شيء لاهلنا بالموصل. أنا راح أبدي بعض السلايدات السريعة عن وضع العراق حالياً. دكتور ثائر بس أكد لي أنه it's full screen now.
No, full screen. Yes.
Okay. حلو. الآن وضع العراق طبعاً هاي السكرين شوتس before a while يعني أخذتها. إحنا وصلنا المرحلة الآن تقريباً 3% عندنا الفيتاليتي ريت، بمعنى death over the total confirmed cases. للأسف الشديد يعني 3%، وكنا تقريبا قبل شهر 4%. فأنا ما أعرف يعني طبعا هل هذه الأرقام حقيقية أو لا. مثل ما تعرفون يعني هي تعتمد على يعني الريجستريشن وشلون دا يصير بالضبط. فالآن تزيد الأعداد، وإذا تلاحظون العراق إذا ما قارناه بدول آسيا تقريبا إحنا التوب 4 بعد الهند وإيران وإندونيسيا. اما بالنسبه يعني طبعا عالميا كتوتال كونفيرمد كيسز فدا ننافس ايطاليا وتركيا وباكستان يعني توب 20. حاولت بعض السلايدات السريعه باعتبار شغلي اللي كان في وزاره الصحه في اداره المستشفيات. وضعنا خطه كان ايضا للامارات، كنت جزء منها. شلون احنا بالضبط نقدر ان يعني هي يسموها البانديميك بريبيردنس بلان، واظن يعني الاساتذه الحضور يعني اكثرهم يعرفون كيف تصير. القصد منها انه نهيئ الموصل على وضع انه تعرفون انتم وضع يعني وضع قطاعنا الصحي بسبب تراكمات الاحداث السابقه وما جرى. فاللي سويناه وايضا بفضل جهود كثيرين يعني من اداره الازمه الدكتور بسام الحجار واخرين فضلاء يعني زودونا بالمعلومات. حاولنا تو كستمايز ذا بلان انه بما يتناسب مع وضع الموصل. فمثل ما تشوف هاي خارطه الموصل. الان احنا عندنا المستشفى ابن سينا في الساحل الايسر، والان مستشفى الجمهوري. هنا عندنا توزيع باقي المستشفيات، مستشفى الموصل العام اللي هو مستشفى العسكري سابقا، مستشفى السلامه هنا، ومستشفى الشفاء، وعنده مستشفى ابن الاثير، واخيرا الخنسه اللي يعنون بالاطفال و يعني الحالات الاوبس اند جاين. المستشفيات اللي تستقبل الحالات الطارئه مثل ما تعرفون مستشفى ابن سينا ومستشفى الموصل العام. المشكله اللي تصير لما يصير اني كونفيرمد كيسز طبعا بالطوارئ هنا يحولوها وكريتيكال كيسز يحولوها الى مستشفى السلام، يعاضدها في ذلك مثل ما تعرفون مستشفى الشفاء. في اي بانديميك بريبيرنس عاده لما يكون هناك مركزيه يحاولون تفكيك هاي المركزيه، لانه لما تستقبل الطوارئ كل الحالات الطارئه سواء كوفيد سسبكتد كيسز او نون كوفيد يعني تكون نوعا ما بؤر لنشر الفيروسات. في هذه الحاله يعني عاده تكون خطط الدول انه لازم يفكون هاي المركزيه بطريقه ما بحيث تتعاون عندنا البرايمري هيلث كيرز او ما نسميه المستوصفات. فبهذه الحاله احنا نحتاج لكثير من الحالات اللي هي يعني اللي خايفين او ما فيري كريتيكال كيسز انه نحاول نفتح قسم من مراكز الرعايه الصحيه او المستوصفات 24 ساعه، يعني على الاقل 2-3 من ما يسمى المراكز الرعايه الصحيه اللي يسموها النموذجيه، اللي تكون عاده تحوي على يعني راديولوجي فيها وفيها لاب او مختبر. بالتاكيد هذه ما راح تقدر يعني ما راح تكون ناجحه الخطه اذا ما حولنا لهم بعض الكوادر سواء من المتدربين الجدد او الخريجين الجدد او قسم من الكوادر من المستشفيات، لان احنا بالتاكيد مثل هذا الوضع لازم احنا نوقف الحالات الطارئه و يعني العفو الحالات الغير طارئه، اقصد العمليات الغير طارئه، وكذلك قسم من الاستشاريات الغير ضروريه. فنحاول نوزع الكوادر وتتوزع الكوادر بطريقه بحيث انه يعني كل واحد يشوف يعني شنو عنوانه اقرب مستوصف له، ولازم طبعا يتهيأ المستوصف. وهاي الخطه تكون بالتعاون مع الصحه مع كافه القطاعات الصحيه. ايضا احنا مثل ما تعرفون الان اذا كانت هذه المستشفيات اللي تستقبل الكوفيد كيسز، فاحنا نحتاج يعني مستشفيات تستقبل النون كوفيد كيسز، اللي هو يعني الخطه البديله عندنا في الموصل اللي هي المستشفيات الاهليه، مستشفى الزهراوي ومستشفى نينوى ومستشفى الربيع. فهذه المفروض يعني تكون لهم وقفه للمدينه، يحاولون قدر الامكان يهيئون المستشفى بطريقه بحيث تستقبل الحالات اللي يعني not suspected cases او ما لها علاقه بالكوفيد، يعني نون كوفيد هوسبيتالز نعتبرها. طبعا يعني قسم من المستشفيات اللي هي التيرشري هوسبيتالز لازم تنقسم ايضا اذا كان بالامكان تنقسم الى يعني قدر الامكان الى مداخل للسسبكتد كيسز ومداخل للاذرز اذا كان في مجال، لانه مثل ما تعرفون يعني يمكن قسم من المستشفيات يعني مدمره وقسم منها اصلا حتى كرفانيه. بس مع هذا يعني مع ذلك انه بالامكان حتى لو كان المستشفى كرفاني على الاقل انا احاول اسوي تراياجنج صحيح. وبالتاكيد لازم احنا يكون تعاون مع الاسعافات تشتغل كلها، يعني حتى اذا كان اكو نقص كادر عددي بالاسعافات المفروض يعني من ابناء المدينه احد ايضا نقدر بحيث احنا نشغلهم فل، ونحاول يعني تعاضدهم في ذلك ايضا البوليس او يعني الشرطه. يعني خاصه تعرفون الحالات لما تكون حرجه عاده الاهالي يكونون ضايجين معصبين كذا، يعني لازم اكو احد تو كنترول ذا ثينجز. مثل هذه الخطط عاده حتى تنجح، وطبعا يمكن احدكم يقول يعني احنا يمكن الان تو ليت، بالحقيقه هاي اول واخر احنا راح نحتاجها. يعني حتى انت اذا كان عندنا صار ديكلاين ونزلت الحالات، مع هذا احنا نحتاجها، لان التهيؤ هذا مو فقط في فتره الموجات، احنا الان من هنا وسنه اقل شيء لازم نظل احنا متهيئين ونتوقع انه يعني يصير ريباوند للكوفيد at any time. فطبعا حتى تنجح هذه بالتاكيد احنا نحتاج الى تراياجينج صحيح، يكون على الاقل تمريض في بوابه كل مستشفى او كل يعني رعايه صحيه اوليه او كل مستوصف، حتى يشوف بالضبط هل في اكسبوجر هيستوري او لا، وعلى اساسها يتم عزل المرضى، بل حتى تقسيم المستوصف او المستشفى الى السسبكتد كيسز اللي تكون بالوسط الصفراء، confirmed cases، وايضا كلين زون او نون كوفيد بيشنتس. طبعا عاده المستشفيات اللي يعني تتقسم كالاتي مبانيها، يعني ايضا كلين، هاي ريسك زون، وسسبكتد زون. ويعني طبعا السسبكتد كيسز يعني اللي انا ما اعرف يعني اشك فيه اخليه في مثل هذه الاماكن. يمكن احدكم يذكر انه مستشفياتنا تعبانه اصلا، ما ممكن احنا نسوي هذا الشيء نقسمها ثلاث يعني اماكن. يعني على الاقل حتى لو مستشفيات كرفانيه او مستشفيات نوعا ما بسيطه، لازم على الاقل تهيئ بتقسيمين، كلين زون وهاي ريسك زون. وطبعا يعني حتى الستاف مالهم لازم ما يلتقون مع بعض، يعني قدر الامكان احنا نقول. وهنا عندي هذا خليت السورس اذا احد يحب يشوف الفول preparedness infectious preparedness plan. هنا راح اعبر هذا السلايد. ايضا احنا عندنا مثل ما تعرفون عاده عندنا المقيم الدوري هو اللي يمسك، يعني هاي احنا عندنا الثقافه بالعراق يمكن ما موجوده باماكن اخرى. الحقيقه هو المفروض في خاصه يعني في فتره كوفيد او في فتره بانديميك، المفروض المقيم الاقدم هو اللي يمسك، هو اللي يكون بالفرونت لاين، والشادوينج يكون هو المقيم الدوري. تلاحظون شلون مع تواجد دائم للفيلو وتواجد دائم ايضا للكونسلتنت. لازم انت عندك فيرست اون كول، سكند اون كول، لانه يعني الحالات الان ده تجي قسم منها حتى حالات كرونيك كوموربيديتيز، اشياء فعلا احنا نحتاجهم باسرع ما يمكن، يعني لا يمكن ان احنا نخليهم يعني لحين ما يجون من البيت وكذا. بهاي الطريقه احنا نقدر على الاقل نسيطر على يعني تدفق او تدهور الحالات الطارئه. طبعا انتم مثل ما تشوفون يعني اذا كانت خارطه الموصل هالشكل، لاحظت انا باستقراء كامل للكريتيكال كير بيدز عندنا هنا مثل ما تلاحظون كم اعداد الاسره لكل 100,000 من السكان. لاحظت وضعنا احنا هنا، حتى نقدر احنا نرفع العدد شويه اعلى بحيث نقدر احنا نسيطر، لابد من ان تساعدني او افتح مستشفيات ميدانيه. وهذا المستشفى الميداني اللي اشتغلوا عليه شباب الموصل بكفاءه، الله تعالى يحفظهم ويرضى عنهم. ما اعرف ايش صار منه، ليش لحد الان مغلق، لانه انا تقريبا عندي الكيسات اولموست فول بالمستشفيات، البيدز اولموست فول. فالمفروض انا دائما افكر ببلان بي، وابدي اذا كان عندي الاوكيوبنسي ريت او نسبه اشغال الاسره وصلت 80%، ابدي افتح قسم من المستشفيات الميدانيه وادعمها بالاجهزه المطلوبه. وطبعا يعني تبدي بمراحل، احنا نقول يعني كل مثلا 10 20 30 بيدز، واذا زادت الحالات ابدي افتح بحيث انا اكون دائما مستعد. وايضا تهيئ بالكوادر الصحيه، حتى اذا ما كان انا عندي اي كوادر صحيه بامكان الخريجين الجدد ايضا ادربهم تدريب سريع ويمسكون سواء تمريض او كوادر اخرى. وايضا اقدر يعني اذا اضطريت ان ادرب حتى الاند ستيج او يعني المراحل المنتهيه ايضا او الريجسترار يعني. فبهاي الحاله انا اكون كنت سويت شيء زين. اذا طبعا هنا خليت بهذا السلايد مجموع البيدز ككل، inpatient بيدز لكل 1000 من السكان، حسبتها. للاسف الشديد يعني احنا بالموصل الهند يمكن تقدر تشوفون اخر شيء، يعني لكل 1000 من السكان صارت هنا، يعني تقريبا احنا لكل 1000 يا نحصل تشرشف من البيد، للاسف الشديد يا ما نحصل. فحقيقه لوضع الموصل يعني وما جرى من احداث، فنحتاج حقيقه تعاون وتعاضد. هنا ايضا عندنا شيء جدا ضروري حتى تنجح الخطه. دكتور ثائر، انا من يعبر الوقت اذا بالامكان انطيني خبر.
يعني try to finish
ان شاء الله هو this is the final ان شاء الله. احنا تكلمنا حتى مع خليه الازمه بضروره وجود كوماند سنتر حتى يعني يكون تواصل دائم عن طريق الكوماند سنتر، سواء مع مراكز الرعايه الصحيه الاوليه اذا كان اكو سسبكتد كيسز يتواصلوا مع الاسعاف حتى ينقلوه للمستشفى المعني، بعد ما يكون تواصل دائم، ونخلي يعني اشخاص معينين هم يتواصلوا مع يعني كل هذه القطاعات، يكونوا مسؤولين حتى عن يعني ارفاد الكوماند سنتر او مراكز التحكم باعداد الاسره وكيف وضعها واعداد الاكسجين الى اخره. اخر شيء احنا حاولنا يعني ايضا مع جهود يعني الدكتور بسام الحجار ودكتور مضر واخرين انه نسوي اي كلينيك، لانه تعرفوا الان ما شاء الله يعني كثير من اطباء الموصل اصلا هم سووا جروبات لعلاج المرضى عن بعد، حتى لانه فتره كوفيد يعني كثير من الحالات احنا نقدر عن بعد على الاقل نحاول يعني نعالج ما يمكن معالجته. فطبعا بدنا نحاول نسوي داتا خاصه ضخمه، وطلبنا ايضا من قسم من الشركات الاتصالات اسياسيل وكورك الى اخره انه يزودونا بسيم كاردز فري، وقفه تكون للمدينه، وهم ما شاء الله يعني صار لهم سنين يعني زبائدهم بالالاف، فالمفروض الان يقفون للمدينه. فبدنا نحاول يعني بطريقه او بحيث يتصل المريض، في عندنا كلينيشنز بالبدايه، بعدين خط الثاني اذا كان الكيس مور كريتيكال تروح لخط ثاني، واخيرا اذا كان مور كريتيكال الجي بيز يقدر يحولها للكونسلتنت. واخر شيء عندي اذا في يعني تايم تو تايم نقدر عن طريق بدالات طبعا، وكثير من اهالي الموصل ايضا كانوا مستعدين، قالوا لنا احنا نجهز لكم هاي البداله بمجرد ان توفروا لنا هاي الخطوط، على الاقل 5-6 خطوط من كل البدالات حتى احنا نقدر نسوي هذه الخطه. طبعا تكمله الخطه راح انزلها انا على موقعي على الفيسبوك، وايضا على جروب دكتورز بيشنتس ان شاء الله. هنا راح انهي، واتمنى الله تعالى يحفظكم ويرضى عنكم ويوفقكم يعني مسح بعض المعاناه عن المرضى واهالي الموصل، واسال الله تعالى ان شاء الله تستفادون اكثر من هذا الويبنار. وشكرا دكتور ثائر.
شكرا دكتور أيمن. Very nice lecture, very nice information, very great effort to collect all this data and to put this action plan. It is not difficult. I think it needs just an intent or intention to do it. I don't think it is difficult. It can be applied in each hospital and each system. So thank you, Dr. Ayman. Thank you for all newcomers who joined our webinar today. Now I will shift the lecture to our Maestro, Dr. Ala Shami, is a consultant internal physician or internal medicine. He will speak about the latest guideline of medical management of the patient with COVID-19. So Dr. Ala, now you are the one who will speak. You can start, Dr. Ala, now. Okay. Should share your slides, please. You are the host now.
Is it clear?
Yeah, clear. Just
Okay,
make it full
clear.
screen. Make it full
Okay.
screen. Full screen.
Okay. Okay.
Perfect. You can start.
Assalamu alaikum. Good evening, colleague. Thank you very much, Dr.Thair, Dr. Ayman, for inviting me to give this lectures, and my salam for all my colleagues in Iraq. I hope all they will be and safe, and I hope they will get some benefit from what we can at least make it in this lecture in a brief that can be give them some information. This is the link from the update guidelines from the National Institute. Easily can go through it for more details and more studying of trials. Usually, when we start a treatment for any disease, we need two important things to approve the efficacy and the safety profile of that medicine. First of all is the strength of recommendation and the quality of evidence for that medicine. What we mean by that strength recommendation, A means the strong, the B is moderate recommendation, C is optional. The quality of evidence, when we have a class 1, when there is more than one well-designed randomized control study with a validated positive outcome, and 2, when there is one well-designed non-randomized or observational cohort study and the third, class 3, is from expert opinion. In fact, this is the panels that updating the management of the COVID-19. From many meta-analysis studies, the symptoms of COVID-19, or what we call it the SARS-CoV-2, they found that most of these symptoms are non-specific, but in general, cough is the main presenting symptoms in more than 50% of the cases. Fever, myalgia and headache, dyspnea, sore throat, diarrhea, nausea and vomiting, loss of smell, of taste, abdominal pain, rhinorrhea. Patient may present with venous thrombopulmonary embolism, TIS, stroke, and sometimes COVID encephalopathy. In fact, when we have suspicion of COVID disease, depending on the symptoms, and especially if there's a strong history of contact with COVID patients, we should confirm the diagnosis. The nasopharyngeal swab specimen is the most recommended one, which give a yield sensitivity more than 80%. Oropharyngeal is not advised because the sensitivity is low, up to 35%. If we can get expectorated sputum, it is also good, 80 to 90%. And if the patient is on a mechanical ventilator, intubated, then bronchoalveolar lavage will give a high sensitive results. Once the result came positive, this is confirming the diagnosis of COVID. But the question, if the result came negative. Negative PCR in the presence of highly suggestive history and abnormal chest finding or high resolution CT scan finding, it does not rule out the COVID. And in this case, we should repeat the test, trying to get a sample from the lower respiratory tract, if that's possible. Again, the panel does not recommend the use of serological test for absolute diagnosis of SARS-CoV-2. And it is only useful if the patient comes later presentation, and it can be add additional diagnostic test for patients who have past history of exposure. It is useful to see is that the patient, especially those who comes with out symptoms and come late. Again, we should understand that as the infection is give a long life immunity, till now it is not confirmed. There is so many randomized and observational studies. They found that the antibody titer after 6 months, more than 70% of it is come down. And this make the risk of reinfection is still high. When we confirm the diagnosis, we should triaging the cases into either asymptomatic, mild, moderate, severe, and critical. And this is depending on the clinical presentation. Usually patient asymptomatic when the PCR is positive in the absence of symptoms, while mild patient would come with the non-specific flu-like illness, and usually the patient is maintaining the oxygen saturation, and also his respiratory rate is usually less than 30. In patients with moderate, the patient will have the symptoms of flu-like illness, but there is signs of lower respiratory tract infection and the signs of pneumonia. And in severe patient, is the most important thing is that in addition to the symptoms of pneumonia and respiratory distress, there will be desaturation. Oxygen saturation is usually less than 93 on room air, and the PaO2, FiO2 ratio less than 300, and the HRCT more than 50% of pulmonary infiltrate. And those who are critical, usually they have the same symptoms like severe pneumonia, COVID pneumonia, but in addition to that, the patient will have ARDS and respiratory failure type 1, or maybe comes with septic shock with multi-organ failure. And usually the level of consciousness in these cases is usually altered. When we diagnose and triaging the cases, we should look for the comorbid risk factor, because this is important for the prognosis of each case one by one. And there is established risk factors, which is nominated by the CDC, the cancer, CKD, COPD, patient immune compromised because he did before solid organ transplant, like renal transplant, a patient obese with BMI more than 30, patient with serious cardiovascular disease, heart failure, and coronary artery disease, and cardiomyopathy, and sickle cell disease. Also in type 1 and type 2 diabetes. There is other possible risk factors, asthma and stroke, cystic fibrosis, hypertension, immune compromise because patient taking systemic steroid and cytotoxic drugs for other connective tissue disease, or patient who did before bone marrow transplant, and patient with chronic liver disease in a pregnancy, pulmonary fibrosis, smoking, and thalassemia. What we mean by hygiene that we should categorize the patient into asymptomatic, those who have either no symptoms or those who have no risk factors and normal chest x-ray. In these cases, no need for admission. They should be quarantined at home with all the precautions at least for 14 days till they become converted to negative. And those who have high risk factors or the chest x-ray is abnormal should be admitted in the hospital in isolated ward. Again, those with mild symptoms without signs of pneumonia, if they have a comorbid risk factors, also they need to be hospitalized. But if they are asymptomatic, also we can treat with symptomatic treatment of quarantine for 2 weeks at home. Those with moderate and severe, those two categories, the moderate can be seen, of course, because of the fever and because of the radiological evidence of pneumonia, they need to be hospitalized in isolation ward, and there is a high risk that they might progress into severe or critical case. So they need general treatment in addition to the specific therapy. Those who have severe and critical cases, in fact, both of them, they need to be admitted to the intensive care unit with a high monitoring and using the second line treatment, antiviral, with all the other supportive therapy. For the management, after we confirm the diagnosis, in fact, we should do the following basic test, the CBC, urine exam, glucose level, including the liver function test, CRP, procalcitonin, ferritin, D-dimer, coagulation profile, fibrinogen, LDH, troponin ice, G6PD, blood grouping, HIV, and those during the reproductive age, pregnancy test should be done. Chest X-ray is important, and the CT scan, those with high risk or the rapidly progressive deteriorating course of illness, and those who have pneumonia, but the chest X-ray is not that much impressive. Again, the ECG should be done for every patient admitted to the hospital. If we look for the lab test that is associated with severe COVID, is that the D-dimer above 1,000, CRP more than 100, LDH more than 245, troponin more than twice upper normal limit, ferritin more than 500, CK more than 2 upper normal limit, and there is absolute lymphopenia less than 800. These parameters and biomarkers are important that can give a clue for the future course of the disease in that patient in order to be aware and to choose the right treatment and for the close monitoring. For the treatment, we have general symptomatic and we have the specific treatment. General, usually the patients, every patient admitted to the hospital should keep oxygen therapy above 94, should be hydrated and hemodynamically stable, should be anticoagulated with a prophylactic dose for moderate. Those with severe and critical without contraindication should be on therapeutic dose, which is 1 milligram per kg enoxaparin. And those with critical and severe should be on stress ulcer prophylaxis with PPI like pantoprazole IV. And for symptomatic treatment, fever, paracetamol is the drug of choice. We should avoid the use of non-steroidal anti-inflammatory drugs as much as possible. For dry cough, we use either the dextromethorphan or codeine can be added. For productive cough, we can use a mucolytic. For nausea and vomiting, metoclopramide IV can be given. And for critical and severe, vitamin C should be added. What about the comorbid diseases for hypertension, for diabetes, for dyslipidemia? or for other chronic diseases, case by case, all these medications should be personalized. For the specific treatment, in fact, there is no specific drug approved by FDA, and all these comes from the separated, randomized, and observational studies from different countries in the world. And for the remdesivir, there is insufficient data to recommend it for mild and moderate cases. But there is randomized control studies and several observational studies found that using remdesivir for those with desaturation and those who are on mechanical ventilator give for 5 to 10 days will reduce the mortality and reduce the stay in the hospital. For the chloroquine and hydroxychloroquine with or without azithromycin, there is no more indication for using it neither in the hospital nor outside the hospital, and the FDA and the NIH and the WHO since the July 2020 they remove it from the line of treatment. For the Calitra, lopinavir, ritonavir, and other HIV protease inhibitors, again, the panel recommend against using them. This is only except in clinical trials, including the ivermectin. Again, the panel recommend against its use, and it's only used for clinical trial. For the blood-derived products for using it in COVID, we have the COVID-19 convalescent plasma. Again, they found that there is insufficient data to recommend either to or against the use of this treatment for COVID-19. But if we consider to use it, it should be used in the early stage before the patient is desaturated. Also, it is not useful in those who are on ventilator, and it should be used only once in a dose of 200 to 250 cc per unit. Up to 1 to 2 units can be used. Again, we should not forget that there is complication for this modality of treatment. There is transfusion reaction, allergic, anaphylactic, hemolysis, acute lung injury, thromboembolic complications, and the cardiac events. And that's why we need for more prospective, well-controlled, and adequately powered randomized trials in order to decide whether this modality of treatment is effective and safe. What about the hyperimmunoglobulin? This is another investigational approach, and they found that still the evidence for its efficacy has not been reported. Again, the panel recommend against the use of the mesenchymal stem cells and against the use of the non-SARS-CoV-2 specific IV immunoglobulin. For all patients in the hospital, there is certain investigation that should be reported, should be repeated every 72 hours, especially the CBC, CRP, the LFT, LDH, ferritin, D-dimer, and the minerals, including glucose monitoring for diabetic patients. The PCR should be repeated after 5 days from the first positive one, and then should be repeated every 3 days till it becomes negative. Then another test should be done after 24 hours. If it is negative, then the patient can be safely discharged from the hospital, providing he is hemodynamically stable and maintaining the oxygen saturation above 94, 95 on room air. The chest X-ray should be done weekly unless there is deterioration of the patient's condition. ECG should be done and should be initially and should be repeated, especially for elderly patients and those with high risk with electrolyte imbalance, those with cardiac arrhythmias, and those who have a past history of ischemic heart disease, cardiomyopathies, and heart failure. So for the treatment, mild disease, only symptomatic treatment. For moderate, they suggest to use the favipiravir, and sometimes we can add interferon-1 beta as a synergistic effect to it. And in case if the patient's condition progress, then we should go to the second line treatment, remdesivir, tocilizumab, and the convalescent plasma having a role only in the early stage of management of the conditions. For hypoxia, we should achieve adequate oxygenation above 94, 95 using high flow oxygen, NIMV, or if the patient is still restless or desaturated, then intubation and mechanical ventilation. For the corticosteroid, dexamethasone and equivalent corticosteroid, whether methylprednisolone or prednisolone, can be used for critical and severe cases. And other complications like arrhythmia, ARDS, acute cardiac injury, and acute renal failure and shock should be treated accordingly. Again, the empirical treatment for bacterial pneumonia, only if there is high suspicion clinically, especially in the early high CRP and procalcitonin, then antibiotic can be covered to avoid the complicated secondary bacterial infection. For VTE prophylaxis, all hospitalized patients must be on anticoagulation. For those who have a moderate, it should be on a prophylactic dose, and those who have a critical and severely symptoms, and especially those who are on mechanical, whether invasive or non-invasive, should be on therapeutic dose of low molecular weight heparin with a dose of 1 milligram per kg twice a day. Paracetamol is the antipyretic of choice, and non-steroidal is the remote one, should be avoided if possible, and nebulization medications should be avoided, especially in asthmatic patients, because it will induce aerolization and spreading of the infection. And we should be replaced by the metered dose inhaler medicine. For the favipiravir, which is inhibit RNA polymerase selectively and inhibit the viral replication, this can be used for mild and moderate cases. And patients in the many randomized trials, they found that the viral clearance on day 5 was achieved in 62.5% compared with 30% those who are only receiving standard care. There is no adjustment for renal failure, and the dose is 1,600 twice a day for day 1, then followed by 600 twice a day for 7 days. For the remdesivir, this is a nucleotide analog product, and it's used for severe COVID-19 in hospitalized patients, those who have desaturated and those who are on mechanical, whether NIMV or intubated. And they found also a very good result in pregnant women. It showed that 92% good outcome clearance compared with 62 to non-pregnant. And also they found that it reduced the mortality rate in those with severe COVID pneumonia with desaturation and on mechanical ventilator. This drug should be not used with chloroquine and hydroxychloroquine because of antagonistic effect. The liver function should be monitored daily, and if the liver enzymes ALT is more than 5 times, the drug should be stopped and should be monitored the ALT till it becomes less than that, then we can restart again. The patient with an estimated GFR less than 30, there is no data about the using, so we cannot use it for the patient with CKD with estimated GFR less than 30. The loading dose is 200 milligram and 250 cc saline or dextrose water over 2 hours in day 1, followed by 100 milligram daily for 5 days, and in some studies up to 10 days. Tocilizumab, this is a IL-6 pathway inhibitor. This is a monoclonal antibody used mainly in rheumatoid arthritis commonly. This drug can be used after ruling out of active TB, whether pulmonary or extrapulmonary TB. Also, we should rule out any invasive fungal infection, any bacterial infection, or other opportunistic infection. And patients with latent TB should be started with the anti-TB prophylaxis before starting tocilizumab treatment. It is indicated for patients above the age of 18, those with hypoxia, and those with lung infiltrate or very high CRP and ferritin more than 400. Again, those with a clinical deterioration, and also it should be aware that not used in a patient with suspected bacterial or fungal infection, those with the thrombocytopenia less than 100 or neutropenia less than 2000. And providing the ALT and AST should be less than 5 times upper normal limit. And the usual dose is between 40 to 65 kg, 400 milligram can be given as single dose. And this dose can be repeated after 12 hours if there is no improvement. For those between 65 and 90 kg, 600 milligram single dose can be repeated after 12 hours if there is no response. Those above 90 kg, we can use the maximum dose, which is 800 milligram as a single dose, and can be repeated after 12 hours to less than 24 hours if there is no response. For corticosteroid, we have a good positive outcome from the UK recovery trial. This is a randomized control study. They tested the mortality rate of patients hospitalized with COVID-19, the 1 month hospitalized, staying for 28 days, and the mortality rate. They found that patients who were desaturated or on mechanical ventilator by using dexamethasone 6 milligram oral or IV for 10 days plus the standard care, it reduced the mortality rate by almost 30%. They found that 29.3 compared with the 41.4 in group without dexamethasone. Again, they found that there is no benefit of using corticosteroid for those who are maintaining oxygen saturation. There is another retrospective study from the Montefiore Hospital from US. They found in this retrospective study that using corticosteroid for COVID with initial CRP more than 20 milligram per deciliter show a significant reduction in the risk of mortality and the need for mechanical ventilation. While if we use it for a patient with CRP less than 10, there is increasing in mortality and increasing mechanical ventilation. So the conclusion of the UK recovery trial that dexamethasone 6 milligram once a day for 10 days should be added for the treatment for severely ill patients, those who are desaturated, needing oxygen, those who are on invasive and non-invasive mechanical ventilator. For interferon, again, they found that the normal interferon 1 response is highly impaired in COVID-19. This is because of the immune exhaustion. And that's why, because of the plasma cytokine storm. And they found that early use of interferon alpha decreased the mortality, but late use of the interferon alpha increased the mortality and delay recovery. And there is some small randomized control study that show that there is benefit from early using of this interferon beta. And the dose should be 8 million, which is equivalent to 0.25 milligram on alternate day for 14 days. There is another recent interest study investigating the use of interferon beta 1A for acute respiratory distress. They found there is no benefit in terms of mortality compared with the placebo. For the convalescent plasma, again, the FDA granted the emergency use for using it from August 23rd, 2020 for hospitalized patients with COVID-19. And the meta-analysis from 15 control study, they show significant lowering of mortality if using it in early stage before desaturation of the patients or before the patient become on mechanical ventilator. But again, the authors found that these studies, most of them, they are either low or very low quality with a moderate or high risk of bias. And they found that the convalescent plasma transfusion improved the survival in non-intubated patients compared with the intubated patient. About the hydroxychloroquine and the chloroquine, there is no more use it by FDA, and by the UK recovery trial, they found that this randomized control study, the 28-day mortality, there is no difference between all the patients using the hydroxychloroquine compared with the other standard care. again, there is no evidence of beneficial effect on hospital stay duration compared with the other. And the WHO removed it from 4th of July 2020. Again, they found that the hydroxychloroquine did not improve the outcome for the non-hospitalized patient with early COVID-19. For the Calitra, lopinavir, ritonavir, again, the NIH panel found that there is no benefit from using it, and they are recommending against the use of Calitra and other HIV protease inhibitors for COVID-19. And again, the recovery trial concluded that there is no beneficial effect in hospitalized patients with COVID-19. The WHO again discontinued the use of the lopinavir, ritonavir, depending on the results of the Solidarity trial for hospitalized patients from 4th July 2020. This is the this chart will show the treatment of COVID-19 and the medication safety profile in those with chronic liver disease. For interferon alpha, there is contraindication in decompensated liver disease. For interferon beta, not specified. For corticosteroids, there is no evidence of increased toxicity in hepatic impairment, so we can use it safely. For favipiravir, again, there is not specified. And for Calitra, there is an increase in those with chronic liver disease. The liver enzymes should be monitored. For the remdesivir, again, the not specified, but if the ALT is more than 5 times, should be stopped. And for the patients who are using chloroquine and the hydroxychloroquine, these both drugs are metabolized in the liver and concentrated there, and the risk of increasing liver enzymes is very high, and that's why it's not advised in those with hepatic impairment. For the tocilizumab, there is, again, it is that not specified in patients with hepatic impairment, and there is no enough study for its use in patients with decompensated liver disease. What about other medications, especially those who are hypertensive or ischemic heart disease? The ACE and ARB, it is recommended by the American College of Cardiology and the American Heart Association. And recently, the breast corona trial, which is a randomized control study comparing those who are using the ACE and ARB compared with those who are not using it, they found that there is no difference in mortality and there is no difference in the 30-day stay in the hospital. For statin, again, they are recommending to continue its treatment during the course of therapy for COVID. Again, the diabetic patient, they need adequate monitoring and good control for their sugar. And usually the insulin is the best drug to be used during the treatment course for COVID. Other medications should be stopped, particularly the DPP-4 inhibitor and GLP-1 receptor agonist and SGL2 inhibitors. Other immune suppressant and immune modulator and monoclonal antibodies for other chronic connective tissue disease or patients with SLE, it should be used depending by personalize the patients and individualize the treatment by taking case by case the risk and the benefit from this treatment. When we discharge the patient after 2 consecutive negative results with the 24 hours apart, and the patient should be at least 3 days afebrile without or minimal respiratory symptoms, and his chest X-ray and HRCT should show a significant improvement. And after discharge, patient should be quarantined at home for a couple of weeks with all precautions. And in case if he has any recurrence or symptoms, he should come for the follow-up. Otherwise, if there is no symptoms, there is no further follow-up. By this slide, I end my lectures, and thank you for your attention. I will leave the mic for Dr. Thair.
Thank you, Dr. Ala. Very nice actually, and informative lecture. For me, this is the first time I see this informative and practical approach of management of the patient of COVID, whether mild, moderate, or severe. Actually, I got a lot of questions for you, Dr. Ala, till I make Dr. Serinath ready to present his lecture. I will ask you just a few questions. You can start with them now. So there is the first question, I think, from Dr. Mahdi Al-Azzawi. He's هو اختصاصي الأمراض الجهاز التنفسي. هو بيسأل عن dexamethasone in patient with cytokine storm. I think you answered this question. Another question from Dr. Layth Mullah Hussein. I will direct this question to Dr. Serinath. He's asking about CPAP. Two questions from Dr. Arwa Fawzi. The first question, Dr. Ala. Dr. Arwa, she is telling they noticed this patient having a lot of pancytopenia. So any approach how to manage them? And the second question, they noticed the patient with COVID-19, they got DM. So what type of DM and how they manage them? Another two questions from Dr. I will give him time to answer them, but give me just to. You can answer. You can
want
answer.
Me to answer it now? Let us start.
Yeah, you can answer. Yeah, you can answer till I make Dr. Just unshare your screen. Unshare, Dr. Ala, unshare your screen. Unshare your screen.
Okay.
You are sharing.
دكتور علاء بس إذا بالإمكان يمكن تسوي ثائر أيضا هوست حتى يقدر يتحكم.
Dr. Thair, can you hear me now?
Yeah. Dr. Serinath, you are clear now.
Okay. See, now I have joined as two people. You can see me two screens on the panel. So I am talking on my mobile and I will share my laptop screen. So can I share my screen now?
You can share, but don't start the lecture till Dr. Ali answer the question. So share.
Yeah,
okay, Dr. Thair, you are the host now.
Yeah, thank you. So
you
I will
enable my share screen.
But give me Dr. Ala. He should give me he should remove his screen.
Ask him to remove, and then I will share my screen.
So
Dr. Ala, just unshare your screen, Dr. Ala, if possible.
Unshare. Stop.
Yes, unshare your. Yes, stop sharing.
Stop sharing. Okay.
Yeah, please. Yes. Now I will go to Dr. Serinath. I will make Dr. Serinath host now. Dr. Serinath, you are host now, so you can share your screen. Go now, Dr. Ala, you can answer a question of Dr. Arwa, please. Tell Dr. Serinath.
The first one is the pancytopenia, isn't it? As I remember, this is the first question. How we manage a pancytopenia in COVID-19?
Yes.
Okay. Patient with pancytopenia, you know, if the patient is his background is normal, this is part of the viral illness. As far as the patient is not having symptoms of bleeding, the platelets up to 20,000 can be wait. No need to any intervention. For the hemoglobin, if she is thinking that the hemoglobin, I mean, up to 7 grams can be also with no need to interfere, unless the patient is old, having ischemic heart disease, patient with heart failure. Then in these cases, we need to support the patient and to keep the hemoglobin in the range of up to 10. Otherwise, in young patients, they can tolerate this pancytopenia without any side effects. Once the patient get past the critical period of the viral illness, which takes 7 to 10 days, everything will come back and return back to normal. What about the second question?
Dr. Arwa, she is telling that they notice these patients with COVID-19, some of them, they get diabetes. So what type of diabetes, this type of diabetes, and what is the approach to manage them?
See, most of the drugs which is used, those who are not diabetic before, it might induce stress and induce hyperglycemia, what we call it stress hyperglycemia. So this stress hyperglycemia, the treatment, during the treatment for COVID should be on insulin. There is no place for oral, especially those with critical and severe COVID. And other issue, when we will use steroid, again, this will induce drug stress hyperglycemia. So we are expecting that the blood sugar will be increased in these cases. So either to use bolus basal insulin, and that is quite, or if those who have not well controlled, especially on mechanical ventilator, they can use the low dose of IV infusion insulin with hourly measuring of the blood sugar to keep the blood sugar tightly controlled.
Okay, good. Tell Dr. Serenat will be ready. Two questions from Dr. Zahra Dawood. The first question, she said, if can we give fresh frozen plasma for normal people to produce more antibody so can protect them against infection? And the second question, if the patient or the person got infection and he quarantined at home, when he is considered free from infection and he can go back to his work and to his normal life?
Usually patients, first question, regarding the convalescent plasma, it is not recommended to be given for healthy individuals. There is no any randomized control study showing that a patient, healthy, normal, getting convalescent plasma will give him a protection. Till now, there is no indication. It is only indicated those who are hospitalized COVID. For the second question you mentioned about the, sorry, can you just remind me?
The second question, person got COVID infection and he quarantined himself at home. Okay.
Okay.
When you considered him, he is negative and he can go back to his life, to his work, so he can see his family and he can meet his friends.
Usually 2 weeks. But the question, how we can prove that he convert to undetected? Here, they are supplying the patients with watch and they are following them. And every 3 days they are coming regularly. And there is a COVID clinic that they are doing for them a swab till they become negative. But in general, the 2 weeks is, I think, if any patient quarantine at home 2 weeks, after this 2 weeks, it is advised to do one screen at least to confirm that it is converted to undetected.
Perfect. Dr. Senat, if you are ready, please just share your screen from anyone. I will remove the other one. But if you go to share screen down and share your screen, and I will move the other one because now you are the host. Dr. Ala, tell Dr. Senat ready. There are two questions. The first question from Dr. Wajih. He said, can COVID came with dyspnea only? No other symptoms?
Yes, why not? Can be. Can present the patient for the first time with ARDS, with COVID pneumonia, especially those who think that it is simple flu and they come late to the hospital. They would come in advance. They come with dyspnea, yes.
Okay. The other question from Dr. Batul Ala Amin, she said, what is your opinion about if an old age patient improve, but still he has high inflammatory marker as D-dimer and ferritin? What's your opinion regarding this one?
If the patient is clinically improved, these markers will take time to return back to normal, providing that the oxygen saturation of the patient is adequate on room air, and second, the HRCT of the patient show improvement. There is one point I want just to mention it about the anticoagulation. This issue is very important because sometimes the patient might present, as you mentioned now, only dyspnea, pulmonary embolism. It might be the presentation of patient with COVID. This should be also put in mind. Even if the patient is young and healthy, it doesn't mean that he is out of risk. The thromboembolic in young patient infected by COVID is reported, whether stroke, whether ischemia of lower limb, whether mesenteric ischemia, whether pulmonary embolism, whether myocardial infarction. And we saw cases young without any comorbid risk factors and admitted with COVID, and the presentation is either myocardial infarction or pulmonary embolism or ischemia of the lower limb. So these issues, please, is very, very important. They should consider it when they are managing a case with COVID.
Perfect. Dr. Srinath, you are ready? You are ready? Just share your screen. Yes. Yes, make it full screen, please, Dr. Srinath. From down. Till Dr. Srinath will be ready. Dr. Ala, there are two questions, rapid questions. The first question from Dr. Wajih. Dr. Wajih is asking about vitamin D in the management of the patient with COVID. This is the question. I have a lot of questions. I will make it later on.
In fact, I will tell you frankly. Vitamin D, zinc, it has no rule. I mean, no harm, but at the same time, no benefit. So you can say it is like a placebo. And even the only thing that what we are doing, that vitamin C, they are giving it for those with critical and severe cases, thinking that vitamin C is important to foster the immune system. Otherwise, I mean, there is no any randomized trial saying that vitamin D is or zinc is part of the treatment of COVID. Although at the beginning of the crisis, all these things are added in the line of a treatment, but subsequently, after the more trials done and more observational studies and data came from the randomized control studies, they found that all these additional drugs has no role in the neither mortality or the improvement of the patient.
There's actually a lot of questions for you, but the last question before Dr. Srinath start, Dr. Mustafa Marwan, he's asking about the role of NOAC during the treatment, during the active phase, can replace deoxycycline, and after the improvement of the patient as an outpatient, is it useful or not? And after you answer this question, we'll start with Srinath, please.
In fact, there is no place till now for NOACs in COVID patients. Enoxaparin, or they can use fondaparinux, especially in cases of thrombocytopenia, heparin-induced thrombocytopenia. They can change to fondaparinux as a safer drugs. They can use unfractionated heparin, but NOACs is not. If the patient is on NOACs, he should change into low molecular weight heparin, and after the patient improvement, he can again reschedule him back to his old treatment, NOACs, like that.
Okay. So there's a lot of question. Again, the question from Dr. Mahdi Al-Azawi. I will ask at the end of the lecture, Dr. Ala, please keep with us. Now, a lot of question, including question from most of the audience for Dr. Ala. But now I will start with Dr. Srinath. Dr. Srinath is our brilliant pulmonologist in the hospital. He is managing almost most of the patients of COVID-19 in our hospital. He will speak about the oxygenation and the ICU measurement for the patient with COVID-19. So mostly he will speak about the ill patient in the hospital. He will not speak about the outpatient. However, if any attendee, our friend, he can ask about oxygen at home, he will be ready at the end of the lecture. So Dr. Srinath, please, you can start your lecture.
Am I audible to all of you?
Yeah.
And you can see my screen?
Yeah, it's clear.
Okay. Good evening to all of you. My name is Srinath. I'm a pulmonologist working in the Fujairah Hospital. I want to thank Dr. Thair and Dr. Ayman for allowing me to present this. And Dr. Ala has done a wonderful job of giving you a very elaborate presentation on how to manage COVID. I'm just going to touch on the most important topic in COVID, because the most common complication of people who present with COVID-19 is hypoxia. They go in for pneumonia and ARDS, and usually that is the cause for their death. So in the last 4 to 5 months, we have seen so many patients with hypoxia, ARDS, and it has been a learning experience for me. And I just want to share my knowledge with all of you. So the COVID-19 is caused by the SARS-CoV-2 virus. It has got a 5 or 7 day incubation period. And starting from the 0 day to the 7th day, the patient usually has cough, fever. He might have hypoxia. 8 to 10 days is the time when the patient develops ARDS and he requires intensive management. 14 to 20 days, if the patient is ventilated, is the time when there's peak risk of death. More than 20 days, you have patients who survive this cytokine storm, the ARDS. They have the risk of developing lung fibrosis, interstitial lung disease. And this is something which we are seeing now, and it has become a major problem for us. So going back to the basics, what are the common causes of hypoxia? Physiologically speaking, there are 5 causes. You have ventilation perfusion mismatch, you have shunt, you have diffusion impairment, you have hypoventilation, and you have low inspired oxygen. In COVID-19, it is the VQ mismatch and the shunt which plays a major role in causing the hypoxia. So this is a complicated diagram, but just look at, are you able to see my pointer? Yeah. So see, this is the VQ mismatch and this is the shunt. So actually, these are actually the pathology which causes this is almost the same. This is a mild phenomenon and this is a more advanced phenomenon wherein you are not able to correct the hypoxemia. So the reason you have to find out if the patient is having a VQ mismatch or a shunt is because the prognosis of the patient who have just a VQ mismatch is good. You are able to correct their hypoxemia, and if they are lucky, they will just come out of it. But if a patient with VQ mismatch does not improve and goes into the shunt pathology, then his prognosis decreases drastically. It becomes very bad. So how do you differentiate between a VQ mismatch and a shunt pathology is by giving a patient 100% oxygen, either by using a non-rebreather mask, and then you do a pulse oximetry. If the pulse oximeter shows that there is good improvement with the saturation once you have applied 100% FiO2, it means that it is a VQ mismatch, mostly. And if it does not improve, then most probably you are having a shunt pathology. The patient needs more close monitoring. The patient needs more intensive management. Okay, now there were people who were saying that this is not ARDS. COVID pneumonia is a completely different disease. It is not behaving like ARDS, and they came out with a hypothesis that there are 2 phenotypes: the L phenotype and the H phenotype. And now the people's consensus is that if you catch the patient earlier in the disease, he is going to have the L phenotype, and if that patient progresses, he is going to have the H phenotype. So it is a part of ARDS wherein you're having 2 ends of the spectrum. The L phenotype is where the patient has a VQ mismatch physiology, and the H phenotype is where the patient has a shunt pathology. He has a more chances of going in for ventilation using lung recruitment maneuvers. So the L phenotype is characterized by a high compliance or a low elastance, a low VQ ratio, a low lung weight, and low recruitability. Low recruitability means that the patient's alveoli are all open. You don't have to use any measures to open up the alveoli to improve the oxygenation. Whereas in H phenotype, you have a high lung weight, you have a shunt pathology, you have low compliance, you have high elastance. And the recruitability is very high. It means that the alveoli, most of the alveoli in the lung are collapsed, and you need to do something to open up these alveoli to improve the patient's oxygenation. Just delivering oxygen to these patients is not going to help them. You have to do something which will open up the alveoli and improve his oxygenation. So Dr. Osama will be telling you a lot about the radiological findings in COVID, but this is just to tell you what type L and type H looks like. The one on the left is the type L, wherein you can see multiple patchy ground glass opacities in the peripheral areas of the lung. It's not very, very extensively involved. Whereas type H is your classical ARDS. You can see that there are white, you can see this is the consolidation in both bases of the lung, posterior basal segments, and there are some areas of air bronchogram. This is your classical ARDS. So these patients, all the alveoli in these areas are completely collapsed. So you need to have some recruitment maneuvers to open up these alveoli to improve the oxygenation. Whereas in this, just giving them supplemental oxygen, because this is just a VQ mismatch phenomenon, just giving them supplemental oxygen might improve. But these are part of the same disease. A patient with L type can progress and become a H type. So it just depends on what progress the patient is making with respect to the antivirals and other treatment options, which Dr. Ala described in his previous presentation. Okay. So how do you assess hypoxia? The most important thing is your clinical acumen, how you, the patient needs to be examined properly. There are certain things which you have to pay close attention to, most important being the respiratory rate. You can have a patient with a very good saturation, 96, 97, but with a very high respiratory rate. Most of these, we have seen some patients with COVID-19 pneumonia who are young, who are able to compensate for the hypoxia by increasing their respiratory rate, by increasing their minute ventilation. But they ultimately go on to develop respiratory muscle fatigue, and they go in for intubation. So if you are able to assess them initially by looking at the respiratory rate, by looking at their accessory muscle use, if there is any paradoxical abdominal movement, all these things will enable you to start them on oxygen. Just don't go by the pulse oximetry, by the saturation, thinking that the saturation is good, so we don't need to give the oxygen. If the patient is looking clinically sick, if his respiratory rate is high, if he's tachypneic, it is always better to give supplemental oxygen despite having a good saturation on the pulse oximetry. So now the question is whether you just go with the pulse oximetry to assess your patient, or do you need to do an arterial blood gas to assess your patient? So arterial blood gas, it's not an easy thing to do. You have a patient who is sick, and to keep on doing it repeatedly is difficult. When you have the facility, if the patient is on a ventilator, you can put an arterial line so that you can remove arterial blood gas samples whenever you need. Otherwise, usually what we say is if the patient's saturation is more than 94, you can just depend on the pulse oximetry. I will show you what the reason is. You need to understand the oxygen dissociation curve for this. So this is the oxygen dissociation curve. On the x-axis, yeah, you can see my pointer. On the x-axis, you have the PaO2, and on the y-axis, you have the saturation. Now, if you see from a PaO2 of 120 up till 70, the oxygen, the body is able to maintain a saturation of around 90 plus. Okay, so when the saturation starts falling below 70, it goes into the areas where you have 90, 85, 86, 87, 88, 89. So 60 is the cutoff for calling it as a respiratory failure. So if you have a PaO2 of less than 60, it is called respiratory failure. So if you see, that corresponds to 80, 85 on your saturation. So from here till here, it can be anywhere between 100 to 90, and you won't know. So doing an ABG will let you know what the actual PaO2 is. So if you can have a patient with a 92 saturation or a 94 saturation with a PaO2 of 70, which is actually bad. But if you just go by the pulse oximetry, you will be reassured that the patient is doing well, he is maintaining good saturation. So if possible, it is always better to do an ABG, but it is not a must. Well, my rule is if the saturation is below 94, or the patient looks tachypneic, he is having labored breathing, it is always better to do an ABG. And another thing is the ABG allows you to tell what the PF ratio is. So the PF ratio is actually the PaO2 divided by the fraction of the inspired oxygen which the patient is breathing. So this FiO2 is actually a variable. It depends upon whether the patient is on room air or whether the patient is taking supplemental oxygen. So in order to make sure that you are giving the right FiO2, it is better to keep the patient on an on-rebreather mask or keep the patient on room air, so that you know that the FiO2 is 21%. So after that, you do an ABG and then you calculate the PF ratio. You actually classify ARDS based on the PF ratio. So if the PF ratio is more than 300, then the patient does not have ARDS. If the patient's PF ratio is between 300 to 200, it is mild, 200 to 200 is moderate, and less than 100 is severe ARDS. So based on this, you will be able to get an idea of how sick your patient is. Okay. So now how you give oxygen depends upon the patient's ventilatory demand. So broadly classify oxygen delivery devices into two things. You have low flow device and high flow device. Low flow device and high flow device are divided based upon the on the device's ability to provide a fixed FiO2. A low flow device, as the patient's ventilatory demand increases, the FiO2 will start changing. If the patient's ventilatory demand is very high, if the patient's RR is very high, the respiratory rate is very high, the patient's the low flow devices will not be able to deliver a fixed FiO2. The FiO2 will start decreasing. For example, in this table, I have written that a nasal cannula at 2 to 4 liters will provide 24 to 35. So this is for a respiratory rate of, say, between 20 and 25. Suppose the same patient starts breathing at a respiratory rate of 30, this FiO2 will not be delivered. It will decrease to less than 25. So in that sense, low flow devices are not meant for patients who are very sick. For patients who are very sick, it is better to go for the high flow devices because you will be assured that the patient is going to get a fixed FiO2 irrespective of his ventilatory demand, whether the patient's respiratory rate is high, whether he is gasping, whether he is breathing with his mouth open, whatever, irrespective of the ventilatory demand, you will be able to make sure that the patient is getting a fixed FiO2. Okay, now though there are a lot of things here, the most commonly used one are the nasal cannula, the simple face mask, the Venturi mask, and this is a new device, a high flow nasal oxygen device, which is a wonderful device, and it has helped us manage in our COVID patients. And you have the non-rebreather mask with a reservoir bag, which will give you around 90% FiO2. So this is the nasal cannula. The nasal cannula, you can use it up to 4 liters per minute. A lot of people try to use it at a higher flow rate. The problem with this is that it can cause crusting of the nasal mucosa, drying of the nasal mucosa. The patient can start having epistaxis, and some people who have got allergic rhinitis and all, this will be an irritant, and the patient will start having nose block and all. So you always have to make sure that you don't use a very high flow rate with a nasal cannula. But this is a very comfortable device. Most of the patients prefer this device because they can communicate, they can eat, and also this device enables them to cooperate with spirometry maneuvers, incentive spirometry, chest physiotherapy, which is not possible with the other devices. So this is the simple face mask. Now the simple face mask, the most important thing is that this has to be used at a flow rate of more than 5 liters per minute. The reason being, you have exhaled air which connects in the face mask. So if your flow rate is less than 5 liters per minute, it will not wash out the exhaled carbon dioxide. So there is a chance that the patient might start rebreathing the carbon dioxide which is staying back in the mask. So always make sure that when you are having a patient on a simple face mask, he has a flow rate of a minimum of 5 liters per minute. Otherwise, you have a problem of rebreathing of carbon dioxide, which can cause CO2 retention. I mean, it's theoretical, but you always keep this in mind that you have to have at least a flow rate of 5 liters per minute. This is also a good device, but the problem is the patient can't communicate, he cannot eat, and if the patient is having coughing with a lot of expectoration, he has to keep removing the mask for expectorating the sputum, which is a bit uncomfortable. And this is the Venturi mask. The Venturi mask is a good device for patients in the sense that you will be able to tell how the patient is doing on the FiO2 which you have given for him. Now, in the Venturi mask, you see there are multiple colors over here. Okay. So now each color has got a fixed FiO2 and a fixed flow rate. So for example, this orange Venturi mask which you see over here, this Venturi has a FiO2 of 50% at a flow rate of 12 liters per minute. Okay, this flow rate will be fixed by the manufacturer. If you see the Venturi mask, if you take it in your hand and see, it will be written what percentage and what flow rate. So it is important that you maintain the flow rate. Otherwise, the FiO2 will not be delivered. So what happens is people put the 50% FiO2 and they see that the patient saturation is 99 and the patient is comfortable. Now they want to decrease the FiO2. So what they do is, instead of changing the Venturi, they go and change the flow rate. They will decrease the flow rate, which is actually not correct. You're supposed to change the color. Now this is 50. You can go to 40. The pink one is 40. So you have to go to 40. Now the pink one has got a flow rate of 8 liters per minute. So at 8 liters per minute, this will provide 40% FiO2. So increasing or decreasing the FiO2 on the Venturi will involve changing the Venturi and also making sure that the flow rate which is prescribed for that particular Venturi is provided to the patient. So this is the non-rebreather mask. The non-rebreather mask has got a reservoir bag which ensures that there is a mixing of the exhaled air and the inhaled air. So that is a partial non-rebreather mask. In a complete non-rebreather mask, there is no mixing of the exhaled air and the inhaled air. The inhaled air is always filled by the oxygen which is being supplied by the wall mount, and it will always contain pure oxygen. So non-rebreather mask can provide you a FiO2 of 90%. But you have to make sure that the bag is always inflated. If the bag is not inflated completely, that means that the FiO2 is less. So always maintain a flow rate which will ensure that the bag is completely inflated. Okay. This is the hero of COVID-19, the high flow nasal oxygen. This combines the nasal cannula with a very high flow rate and with FiO2 which can reach up to 100%. Okay. This will enable the patient to talk, to eat, and he can also cooperate with spirometry exercises to improve his lung function. So this is very good. The thing is, it's a bit costly and it is not available everywhere. In our hospital, we had 2 machines. We are in the process of getting 2 more, but it is a bit difficult. So here you have 3 factors which can be monitored. You can monitor the temperature. Okay, you can set the temperature, the humidified temperature which you want. You can set the flow rate. It has got a maximum flow rate of 60 liters per minute, and you can change the FiO2. Okay, so the FiO2 can be monitored, the flow can be monitored, and the temperature can be monitored. It is a very good device. Okay, so for all the patients who are on oxygen, irrespective of whether they are on a simple face mask or on nasal cannula, on NIV, on high flow nasal oxygen, or intubated, proning enables them to improve their oxygenation. So this is called awake proning. Earlier, we used to do proning for patients only who have been intubated to improve their alveolar recruitment. But with this COVID, the awake proning, which was done before, but was not very popular. But now with the COVID-19, in order to avoid intubation, we have made it a protocol that all patients who are on oxygen, if they can tolerate proning, you prone them. So this is how the patient is proned. And this proning will help the patient improve his oxygenation. And you have to stand after the patient is proned. You have to stand there. If, for example, if the patient is very obese, he has got a big tummy, it might cause some discomfort. So you have to stand there for at least 15-20 minutes to make sure that the patient is comfortable with the proning. He does not have cough. He does not have respiratory distress. And you have to make sure that the patient is told that if he is not comfortable, he can always go back to the supine position. If proning is not helping him, you can try the right lateral or the left lateral position with the same effect. So this is how proning helps. So when the patient is supine, the alveoli which are in the basal parts, you saw, no, in the CT, the basal parts of the lung are the most commonly affected. So these alveoli are collapsed. But as per the body's blood flow of the lung, the blood flow is the maximum at the bases and very minimal at the apex. So you have got a very big VQ mismatch or a shunt going on over here. The alveoli which are in the front are over distended, whereas the alveoli which are in the back are completely collapsed. So when you prone them, this alveoli also get oxygenated, they improve, and then your blood supply is maintained. So the VQ mismatch is improved and the patient's hypoxemia is improved. So this is where for oxygenation by oxygen delivery devices. For assisted ventilation, you have got non-invasive ventilation and you have got invasive ventilation. Non-invasive ventilation, invasive ventilation, they are all aerosol generating procedures. So you need to be very careful when the patient is on an assisted ventilation. It has to be in a negative pressure room. If you don't have a negative pressure room, make sure that you're always wearing PPE when you're entering into the room. And you always make sure that the expiratory limb of the non-invasive ventilator has a HME filter that helps in preventing too much spread of the virus. So non-invasive ventilation are of 2 types, CPAP and a BiPAP. CPAP is continuous positive airway pressure, where you have a single pressure throughout the respiratory cycle. Whether the patient is inspiring or expiring, you will have a single pressure support for the patient. So if you are using a very high pressure support, it will become difficult for the patient to exhale against a very high pressure. So in that case, you go for a BiPAP. A BiPAP is more comfortable for the patient because you've got 2 pressure settings, an IPAP, which is the inspiratory pressure, and an EPAP, which is an expiratory pressure. So in this, the patient is able to breathe against a lowered pressure, so he feels more comfortable and he doesn't fight the ventilator. So this is what I was telling you. So you can see this full face mask and you have a single limb, and there actually you're not able to see it clearly, but here there is an expiratory port over here. So this should not be used when you're using it for a COVID patient. This is not supposed to be used. This limb can be changed, or you can put a seal over here and then you put a Y connector over here. So you will have an inspiratory limb and an expiratory limb. And on the expiratory limb, you just put a HME filter and leave it open to air. Okay, and you have got special exhalation valves also. If you are able to get it, it's well and good. But otherwise, you can just put a HME filter on the expiratory limb. Invasive ventilation, the most important thing is when the patient is being intubated, the least number of people, the minimum is 3 people who are required to be there inside the room when the patient is being intubated. Always use the most experienced of the anesthetist or airway people who can intubate. Always use a video laryngoscope. And always make sure that the limbs, the inspiratory expiratory limbs have got HME filters. These patients, they require very high PEEP to maintain oxygenation. So you have to have inline suction catheters. So these inline suction catheters make sure that you don't have to disconnect the ET tube from the ventilator for doing suctioning. You can do a suction when the patient is being ventilated with the high PEEP. So inline suction catheter is a must for patients with ARDS requiring high PEEP for oxygenation. So you must have read about ARDS net protocol, how to ventilate a patient who are on who are having ARDS. So it is low tidal volume ventilation. You have to take the ideal body weight, which is, there is a formula, measure the height of the patient, and for the ideal body weight, you have to give 4 to 6 ml per kg tidal volume. You can use either, you can use pressure control ventilation or volume control ventilation, doesn't matter. We usually prefer pressure control ventilation, and we increase or decrease the pressure to achieve the target volume. You start with 6 ml, and then if the patient is tolerating it, if the oxygenation is good, you can slowly decrease it to 4 or 5 ml. Or you can start at a higher volume, and then slowly you can decrease it as the patient tolerates it. So the lung protective ventilation is basically because if you over-distend the alveoli, you have got something called barotrauma, ventilator-induced lung injury, which will be very similar to ARDS, which can also cause a cytokine storm, which can cause worsening of the patient's clinical status. So this is the reason why we have to make sure that lung protective ventilation is used for all patients with ARDS. So to make sure that you're not over-distending the alveoli, you have to make sure that the plateau pressure is always less than 30. You have to titrate the PEEP and FiO2. There are two ways you can do it. You can start with a high PEEP and a low FiO2 and then decrease, or you can start with a high FiO2 and a low PEEP and then titrate it. Usually we go with a high FiO2. We start with 100% and a PEEP of say around 8 to 10, and then slowly we start increasing it based on the ABG results. These patients who have lung protective ventilation, because of the low tidal volume that you're using, they usually have hypercapnia. But this hypercapnia is not harmful to the patient. You can allow it to an extent, not very bad. So if the hypercapnia goes say 55 millimeter of mercury, then you can start increasing the respiratory rate to bring down the CO2. The maximum respiratory rate that you can go up to is 35 per minute. Then with all these things, you should also, if the patient's oxygenation is not improving, then you go for the next step. You have to recruit the alveoli. Recruitment of alveoli is done mostly by proning. But proning is not successful in all patients because it is a labor-intensive process. You need at least 4 to 5 people, and it is very difficult to prone patients when you have got a lot of patients on the ventilator. So it is a labor-intensive process, and everybody has to be on the same page when you are proning a patient. Otherwise, you can have a catastrophic result wherein the central line is dislodged, or the ET tube is dislodged, or the patient crashes. So you have to be very careful. And as I said, with proning also, there is a possibility that the patient might not tolerate it. He might develop hypoxia. He might develop CO2 retention. So you have to do an ABG after you prone the patient. You have to be there and monitor the patient. If the patient is not doing well, you have to supine him immediately. Incremental PEEP is where you try to stack you try to stack PEEP. You have to increase it. Say, for example, I have a patient who is on say 12 centimeter water PEEP. I increase it up to 16. 16 is very high. So from 16, I maintain 16 say for a minute or two, and then I come back to 13. Then from 13, then again I go back to 16, then I come back to 14. So by doing this, slowly I'm trying to distend the alveoli in such a way that the patient does not have more chances of barotrauma. Inverse ratio ventilation is basically where you are increasing the inspiratory time. Usually in a respiratory cycle, we give more time for expiration. But in inverse ratio ventilation, we give almost equal time for inspiration and expiration, or sometimes we give more time for inspiration than for expiration to improve the oxygenation. If all this fails, then you don't have anything more to do. You have to refer the patient to a center where they can do ECMO, extracorporeal membrane oxygenation. It is a veno-venous process where you have a separate machine. I'm not very familiar with this, but this is up to lung recruitment we can do. But after that also, if the patient's oxygenation is not improving, if he is young and if he is fit for ECMO, it is better to transfer him to a referral center. So weaning, you have to be ready for a prolonged ventilator course. It is not like the other ARDS where you can expect the patient to improve rapidly. Here we have patients who have been on the ventilator for 15 days, 20 days. So, and also the other problem is these patients will require high doses of sedation and muscle relaxant, so they will have a lot of myopathy. We have been using benzodiazepine for these patients, so they have a lot of delirium and they are coming out of this sedation. So it becomes very difficult to manage them. They are very aggressive, they are agitated. And this tracheostomy helps in the sense that once you have tracheostomized the patient, the need for sedation and other things decreases. So the patient's orientation and other things become improved, and he's more cooperative with the weaning process. But there are two schools of thought. Some people say that these patients usually don't need an early tracheostomy. You can wait and try to wean them, and the natural process, you can wait up to 20 days, 21 days to wean them. It is up to you. You can either decide on an early tracheostomy or a late tracheostomy. Early tracheostomy, the reason being, you can decrease the sedation, you can decrease the benzodiazepine, and you can make the patient more cooperate with the weaning process. And another important thing which I wanted to talk to you about is post-COVID lung fibrosis. We are not sure which are the patients who go in for lung fibrosis, but all the patients who were ventilated, they always had a prolonged course of weaning. To take them off oxygen, it was very difficult, and more than 50% of them required some form of oxygen when they were discharged from the hospital. So we usually used to send them with oxygen concentrators. They were usually on 2 to 3 liters of oxygen or nasal cannula. We are still seeing them in the OPD after their discharge, and some of them at rest, they are maintaining saturation, but even with minimal exertion, they are desaturating. So I don't know how this thing is going to be managed in the future. We have tried using pirfenidone and nintedanib, which are actually antifibrotic agents, but there is no recommendation for these drugs. So we are not allowed to use them as such. And this fibrosis does not respond to steroids. So there is no point in giving steroids once the patient has developed post-ARDS fibrosis. Okay, so the take-home messages are, you can prone the patient, awake proning in all patients on oxygen. Try to assess oxygen status on room air for every patient. There can be inter and intraday variations in ABG. An ABG in the morning might be good, and an ABG in the afternoon or the evening might be bad. And this is quite common in these patients on the ventilators. Try to restrict the fluid intake. Try to keep the patient in a negative balance so that the lung weight is less and the patient's outcome is improved. So I want to end my talk with this photo of the 1918 Spanish flu epidemic, the pandemic. So there, at that time also, there was a lockdown, the people are wearing masks, and 100 years later, we are doing the same thing. So nothing much has changed. So until we have an effective vaccine, I think we have to stick to these preventive measures and make sure that we don't get COVID and we remain safe. Thank you.
Thank you, Dr. Sirna. Thank you, my dear friend. Very nice lecture, very informative and practical. Actually, for this information, we got it from your lecture. Now, I think most of our friends attending this webinar, they can manage the patient according to the guidelines you showed it, or to the protocols you showed it to us. They can manage them in the ICU. There's a lot of a question for you, Dr. Sirinath, but I will give you one question till Dr. Osama will be ready to share his screen. So, Dr. Sirinath, first of all, unshare your screen. Second, there is the first question, the other will be asked later on. So the first question for you, Dr. Sirinath, from our friend, Dr. Hussein. He is asking that in our city, we have a hospital almost destructed, so we can, or destroyed, so we cannot admit every patient to the hospital. So some of the patients, even they need CPAP or BiPAP, they can manage them at home. So is there any disadvantage of using CPAP or BiPAP at home?
You're talking about the, am I audible?
Yeah, audible. Yeah, audible and visible. Yeah.
Are you talking about the infectious complication or for the patient himself? For
no,
the infectious
no. Yeah, mostly he's asking about the machine. Yani, is it safe to be used? If I used it, is there any complication related to this machine? Yani, mostly?
No. There are no complications, provided the patient is an intelligent one and he understands how the machine is to be used. And you have to tell him the red flag signs that even on the BiPAP or the CPAP, if he is having labored breathing, or you can, if he can afford a CPAP, obviously he can afford a finger pulse oximeter. So you can give him these red flags that if the saturation is going to go below this, or if your respiratory rate is going to go above this, he can use it at home. It is not a big issue. You can use it at home.
Thank you. So Dr. Ala, Dr. Sadat, please keep with us, stay with us. Dr. Osama now, share your screen. Dr. Osama, he's our actually brilliant radiologist. He helped us too much for diagnosis of the patient COVID, and he actually has a YouTube channel for radiology cases. So anyone he want to review his channel, he can review it. Dr. Osama, you are now unmuted. Just share your screen. Share it.
Please, can you change the host?
I think, who is the host now? Dr. Serenath, please shift the host to me or to Dr. Osama. Just go to the name of Dr. Osama, make right click, you will get more. So one more, make host. Dr. Serenath, please. Go to the panelist name. Go to the panelist name, Dr. Serenath, and go to the name of Osama Ibrahim and make him host so he can share his screen.
Dr. Thair.
Yeah.
This is I can go on this, and when I click on his screenshot, it's only showing chat or pin video.
No, go to his name on the right of the screen. Right of the screen, there is a name. Panel. Go to the participant. Down the screen. Go participant. You see participant?
Okay.
No.
Yeah.
Press on it. Press on participant. Okay. You will get panelists and attendees. Press on panelist. Go to the Osama Ibrahim. Put the arrow on him. More. Make him host.
More is not coming.
Go to the other link for you. You have two names, Doctor.
Okay, so Doctor, that has to be done through.
From this one. Yeah, from this one. No. From this, from your, from the. Because we
just by click on the name of Dr. Osama, then right click, it will show more. There is options. You will choose the make host.
Because I think Dr. Serenath is using another one.
So you tell me how to do it on. Yeah, how to use it on my this.
So use the other name, okay, for you.
Okay. I will do it
use it. Yes.
Make host. Okay. Yeah.
Make now go to.
No, I've made it. Dr. Osama, I've made it. Yeah.
Perfect.
Sorry.
Dr. Ala, Dr. Serenath, please keep with us.
Yeah. Sure.
You have a lot of questions at the end of the lecture will be presented by Dr. Osama. Dr. Osama, please, you can start. Share your screen.
Okay, it's share now.
Yeah, share. Just make a full screen. Make it a full.
Okay.
Let us see it. Yes. So, Dr. Osama, he is showing his lecture. Just look to his YouTube channel. If anyone want to follow or to ask him, he has a very informative channel in the YouTube. A lot of cases, real cases. Okay, Dr. Osama, you can start, please.
Okay. Good evening. Thank you, Dr. Thair, Dr. Ayman, and Dr. Ala, Dr. Serenath, for this chance for sharing my presentation. Actually, I've heard a lot of confusions about SCORAD. So my presentation today is for eye to eye with everyone about that matter. I will talk today about the SCORADs step by step for proper diagnosis of COVID-19 through 13 cases from my daily work examination. So let's start. The learning objective from my presentations is how to discriminate the CT SCORADs type or score from 0 to 6, and how to be familiar with specific patterns and signs of HRCT, which is very important for grading or scoring this score of the SCORADs, like central nodules, the perilymphatic nodules, the tree bud sign, crazy paving, the interlobar receptor thickening, honeycombing, and sure ground glass, which is very important for diagnosis of the COVID-19 and for scoring of SCORADs, and also differentiated from consolidations. So this lesson is gonna be short and sweet, but we are gonna get to the bottoms of this as we see in the next slides. As we know, this is the secondary pulmonary nodules, which representing the main functional and anatomical units of the lung parenchyma. And these nodules, as we see, the green lines is representing the small airway and the terminal bronchioles and airways, and any disease of this is called the small airway disease. And the red lines is terminal arterioles, and any disease within it is representing vascular disease. And the pink one is the airspace or the alveoli. Every secondary pulmonary nodules have from 15 to 20 alveoli for gas exchange. So any disease in this is called the airspace disease, and it is surrounded by a septa, which is a blue one, and this septa contains the venous and the lymphatic drainage. So any the pathology in the venous or lymphatic drainage representing interlobar septal thickening. This little but very common words can cause radiology learners quite and a few headaches. They're very similar also in meaning, but not used on the same way. It's easy to confuse them. However, if we can know them, we can know the diseases of each one and discriminate it from each other. The main issue here is the airspace disease, which if there are airspace disease, it causing the pneumonia and the COVID pathology also. So now, what is the CORADS? The CORADS meaning CO from COVID-19 and RADS from reporting and data system. And these reporting and data systems are scored and classified by those authors in the April 27, 2020. And these CORADS to understand that it is talking about the possibility of the COVID-19. So the scoring of CORADS is talking about the possibility of COVID-19 from the HRCT study. It is not talking about the severity. So I prefer to starting by the CORADS 5 because CORADS 5 is very typical signs and representing very high possibility of COVID-19. And if there are these findings which representing the typical findings in the HRCT, so I suggest the COVID-19 is very high possibility, and also I classify it as a CORADS 5. These typical findings is classified as a presence of ground glass opacity. As we see the ground glass opacity here in the peripheral distribution of the film, the ground glass opacity should be peripheral and based on the pleural surface, and also should be multiple. So the three items to diagnose the COVID-19 as a typical finding in the HRCT: presence of ground glass opacity, then peripheral locations and based on the pleural surface or fissural surface, and third one is the multiplicity. However, if there are any exceptions, like I will talk now, this considers as a CORADS 4, and the CORADS 4 meaning COVID-19 is high suspected and not very high. It is high because the findings are not extremely typical. What is these exceptions? The first one is not located in contact with the visceral pleura. So if the ground glass is peripheral but not located in the contact of the visceral pleura, it considers the CORAD 4, not CORAD 5. The second issue is unilaterality of the, if these lesions is typical like CORAD 5 but unilateral only, I consider it CORAD 4. The third one is the presence of peripheral and central ground glass opacity, but the central is predominant more than the central, so I consider it also a CORAD 5. And the last one, if there are underlying or pre-existing pulmonary abnormality and the consolidations occurring on this abnormality, so I consider it also CORAD 5. What about the CORAD 2? CORAD 2 meaning COVID-19 is low. And CORAD 2 is diagnosed or classified according to the HRCT finding. If I find one from these three issues, which representing centrilobar nodules, like these centrilobar nodules away from the fissure, away from the pleural surface, or tree embed signs like this tree embed, or presence of cavity, or consolidations when appearing lobar, I consider these infections but not COVID infections, and so classified as a CORADS 2, and CORADS 2 meaning low possibility of COVID-19 diagnosis, CORADS 2 due to cavity, tree in bud, centrotubular nodules, or consolidation. I consider it low possibility of COVID-19 and classified as a CORADS 2 at that time. However, CORADS 3 is indeterminate or unsure, and if I find the ground glass opacity central or perihilar only, and not peripheral distributions like this ground glass opacity all perihilar in distributions, so I consider it CORADS 3 because there are ground glass opacity but not peripheral in location. And what is the meaning of CORADS 3? Unsure or indeterminate diagnosis of COVID-19. The CORADS 0, if the examination is done and incompleted or insufficiently quality or severe artifacts, I consider it CORADS 0, and this is not interpretable. And CORADS 6, this occurring when I follow up patient known case of COVID-19 by positive RT-PCR, and I follow up him by or her by the HRCT. So the CORADS here is 6, not 5. I don't make grades or scoring of CORADS. Like this patient, the first row representing the initial examinations in the 4th March, and this is diagnosed as a CORADS 5 because have the typical finding of COVID-19 as there are ground glass opacity, peripheral distribution, and multiple. If these 3 items are available, so I diagnose it as a CORADS 5. However, when the follow-up study done at the 15 March, as the blue row, as this lower row, so I diagnose it as a CORADS 6 now because I know already that patient have positive RT-PCR test. Okay. The CORADS 1 is the remaining type of CORADS, and this is meaning highly unlikely diagnosis of COVID-19. First, if the patient is symptomatic by fevers or shortness of breath, but the HRCT is completely normal, so I diagnose it as a CORADS 1, highly unlikely, because still there are possibility to be COVID-19. Non-infectious disease like emphysema or peripheral nodules of sarcoidosis, lung tumors, or lung fibrosis, all these non-infectious disease. And if I find honeycombing like this representing fibrosis, I classify it as a CORADS 1, which meaning a highly unlikely diagnosis of COVID-19. The third situation is the smooth interlobar septal thickening like this with pleural effusions. Also,
I think some
like
internet
this.
connection. Yeah.
Hello? You hear me?
No, we are hearing. Yeah, some interruption happened. Yes, now we are hearing you. Yeah, continue.
Sorry, you want to
no
repeat
problem.
anything?
No. Continue.
Okay. Okay, now I want to finish up today's lessons with a fixed expression that seems to challenging these rules a little. So let's practice better on the films in daily cases to show all CORADS types in real situations. First is this patient showing multifocal areas of ground glass opacity, and this ground glass opacity is based on the pleural surface. So the diagnosis here, typical findings of the COVID-19, meaning very high possibility, and classified as CORADS 5. And the CORADS 5 here, if we look at the frontal chest radiograph done on the same days, there are subtle changes also noted in the peripheral of the film and at the regions of the ribs, which are unclearly discriminating. And these subtle findings cannot be diagnosed as CORADS actually, like this one. And the CT confirming the diagnosis by the 3 findings, which is peripheral, multiple, and ground glass opacity. And the patient in the examinations or laboratory test was positive also. Next case showing ground glass opacity, which appearing subtle at the superior segment of the lower lobe, and also there are nodules which called invasive halo sign because there are halo surrounding the nodules like this halo of the sun. And the findings, all the findings are unilateral. It is peripheral and invasive halo sign. So I diagnose it as a CORADS 4, not CORADS 5. This meaning a high possibility of COVID-19. Also, patient in the laboratory test was positive. This HRCT for the patient showing these 3 bad signs like this picture, and the 3 bad signs appearing due to terminal airways diseases and filled with secretion. And this meaning one finding from the low suspected diagnosis of COVID-19 and diagnosed as accurately 2. Laboratory test done for that patient and also was negative, confirming the classifications or the score of Coraz. Another patient with ground glass opacity, which distributed at the central and the peripheral distributions. It is based on the pleural surface also. There are interlobar septal thickening, the frontal chest radiograph showing area of consolidations, which appearing also in the lower and the middle zone of the left lung. And the diagnosis here is Coraz 4 because the unilaterality of the abnormality, and this meaning a high possibility of the COVID-19 diagnosis, which also confirmed as a positive in the laboratory test in the daily work cases. Another case which which is symptomatic, but the HRCT appearing, this is a coronary format and this is axial imaging, no consolidations, no ground glass, no invasive halo signs. It is completely normal. However, due to the patient is symptomatic, so I consider it Coraz 1, which meaning a highly unlikely diagnosis of COVID-19 for laboratory test. Laboratory test when done, unfortunately, this patient was positive. So the Coraz ones not meaning it is negative for COVID-19, it is meaning unlikely, highly unlikely for COVID-19 only, and the diagnosis was positive for that patient. Another example for ground glass opacity, which appearing here, and this area of consolidation with air bronchogram. The ground glass opacity, I can discriminate the vessel through it, not in the consolidations as we see, and these consolidations away from the fissure, away from the pleural surface, so it is distributed in the middle of the lung and perihilar locations only, no peripheral, and the frontal chest radiograph for him showing bat wing appearance and parahilar paracardiac consolidations also, and these features are classified as a Coraz 3. A patient was negative for RT-PCR, and the Coraz 3 meaning unsure or indeterminate diagnosis of COVID-19. It can be positive also, but here, fortunately, patient was negative in RT-PCR test. Another example for the ground glass opacity, which based on the fissural surface, in the pleural surface, in the peripheral distributions and the multiple, as will this patient also, which showing a multiple invasive halo sign and the ground glass opacity in both lung fields and the peripheral distributions. By this criteria only, I diagnose it as a Coraz 5 because the 3 items are available here on the film. However, because this patient A have pulmonary embolism, so it is diagnosed as a Coraz 4 because there are underlying lung disease. And the other patient also have lung cancers and hypertension. So the features of the Coraz 5 when put in the underlying lung disease, it's considered as a Coraz 4, which meaning a high suspected COVID-19. Actually, RT-PCR confirm diagnosis of the COVID-19 in the first one and the negative for the other one, but the Coraz is high suspected in both. Another case of multifocal areas of ground glass opacity and the peripheral distributions in pleural base, fissural base, the typical features of the Coraz 5, which showing also in the minimal intensity projections here and the coronary format imaging. There are area of consolidation as a basal lung, all features of the COVID-19 as a Coraz 5. Coraz 5 meaning a high, very high suspected of COVID-19. What about the RT-PCR test? It is positive for that patient also. Here we have ground glass opacity which distributed the perihilars and in center of the lung, as here and there, this area of ground glass opacity, and also in the coronary format imaging, the ground glass opacity still in the center, not based on the fissure or the pleural surface. So it is diagnosed as a Coraz 3. Coraz 3 meaning indeterminate or unsure diagnosis of COVID-19. Laboratory test done for that patient and was positive, and the follow-up studies showing the deteriorations of the finding in the HRCT, as we see comparing with this initial study, the coronal imaging showing multifocal areas of consolidations and the ground glass opacity in the pleural based also, as we see in the follow-up study, and patient was positive. This frontal chest radiograph for patient symptomatic, and there are subtle findings like this opacity, and also the peripherals can be show some opacities also. This findings is subtle in the frontal chest radiograph, as we see, and HRCT is recommended. HRCT confirm the presence of these multiple pulmonary nodules, which is called invasive halo sign like this sun. And the presence of invasive halo signs actually I facing a lot of cases by this finding only and diagnosed as CORADS 5 and also was positive in the RT-PCR. However, because this finding of ground glass and invasive halo signs is unilateral, so I consider it a CORADS 4. CORADS 4 meaning only high, not very high, high possibility of COVID-19, and the RT-PCR test confirming the positive and the detections of the virus in that patient. Another case also showing multifocal areas of invasive halo sign like this one, and also this one in the superior segment of the right lower lobe, area of ground glass opacity, as we see here, based on the pleural surface, and all findings in bilateral and based on pleural surface presence of invasive halo sign raise the possibility of diagnosis of CORADS 5, which meaning very high possibility of COVID-19. What about the laboratory test? The laboratory test was positive also for that patient, and the frontal chest radiograph showing subtle veil-like opacity, as we see here. Another patient with frontal chest radiograph, which is showing subtle area of opacities are distributed on both lung fields, as we see in the distributions central and the peripheral also, because we cannot discriminate the ribs in the peripheral region. And the HRCT, when done, showing by areas of consolidations at the perihilar regions bilateral. However, there are also areas of ground glass opacity in the peripheral aspect of the lung, pleural based. So the features is typical for the COVID-19 should be diagnosed as a CORADS 5. However, because the predominance of the perihilar distribution more than the peripheral, I consider it this one from the exceptions which transfer it to the CORADS 4, which meaning only high possibility of COVID-19, but RT-PCR test also was positive for that patient. Another case which is showing a cavity in the frontal chest radiograph at the right upper lung zone, which is confirmed also by coronal and sagittary format imaging. Presence of these three embed signs, which looks like these pictures of the three embed and the cavity, as well as consolidations area, making the diagnosis of the CORADS 2 is very clear. And the CORADS 2 meaning low suspicious COVID-19 diagnosis. What about the RT-PCR for that patient, 35 years female, who presented with cough only? The RT-PCR was negative for that patient, and the findings are clear for the CORADS 2. Okay, now let's summarize my presentation, and I hope that I have given you some interesting ideas. It's gonna help you to become more fluent and more confident when facing our HRCT patient of COVID-19. And my summary is summarized in 2 slides. The first slide is you should be familiar with the HRCT findings as we mentioned before, and the second slide is should be know how to classify the CORADS from 0 to 6. Thank you very much for your listening, and have a nice day.
Thank you, my dear Dr. Osama. Very nice presentation, simple and clear, and it is very informative. Now I want all the speaker to unmute himself. So we will start answering the questions, please. So unmute yourself, Dr. Ala, Dr. Ayman, Dr. Serinath. I will start the question. I will start Dr. Osama. Dr. Osama, do you recommend CT, high resolution CT for every patient suspected of COVID, or according to the clinical picture?
Yes, actually, I make a lot of requests for the MOHAB and for the my company to do this as a screen for the patient HRCT, because as we see in our cases, in daily work cases, the frontal chest radiograph is the subtle finding in the frontal chest radiograph. In the same days when we do HRCT, we see findings sometimes reaching to Coraz 5 or 4, which meaning high or very high possibility of COVID-19, and laboratory test when done after 24 hours or the result when appearing it was positive also. So HRCT is very good tool for the dealing with these patients, especially patients when are symptomatic, to discriminate them from the beginning, and also to isolate them and away and avoid also transmissions of infections to surrounding.
Perfect. Now I will start the question for Dr. Ala. A lot of questions, but please can you answer it fastly, because almost now we passed more than 2 hours since the presentation. So first the question from Dr. Mahdi Al-Azzawi, هو اختصاصي أمراض جهاز تنفسي. دكتور علاء, Dr. Mahdi asking you, what about the new updating use of steroid in severe COVID-19, maximal doses in high storm days, other than the regimes of recovery trial study?
See, for corticosteroid, the recovery trial showed the dexamethasone 6 milligram once a day, whether oral or IV, for 10 days. But the other observational studies also show that equivalent dose of prednisolone 40 to 60 milligram per day, or they can use methyl prednisolone in the range of 1 milligram per kilogram body weight, divided or split it into 2 doses per day, is also give the same results. But there is no indication for further increase the dose, because we should understand what is the rule of this steroid is to reduce the inflammatory reaction, which is seen in patients with severe and critical COVID. But if you go to the high doses, you will compromise the immune system. So it will have a deleterious effect rather than benefit.
Okay, Dr. Srinath, you are with us, still with us, or you left?
Yeah, I'm here.
Yeah, so 2 questions for you, Dr. Srinath. Yeah. Then we'll ask other questions. The first question,
just a sec, the previous question was, they're asking that you have given a patient with dexamethasone 6 milligram OD, and the patient has gone in for a cytokine storm now. So whether there is any added advantage of giving very high dose steroid rather than the dose recommended by the dexamethasone. But we have had patients wherein you have given them steroids for 7 or 10 days, but the patient has progressively deteriorated, and then he has become intubated, and then you go for a cytokine storm where the CRP is high, the procalcitonin is high, everything starts going up, the ferritin, LDH, and also now the patient is in cytokine storm. So after having completed the steroid course, is there any role of giving high dose steroids at that point of time? Or you have already completed a dose of steroid, you have completed 7 days. So is there any role of giving further dose of steroid? I think that is what the question was, isn't it?
Actually, this is...
He asked for high dose.
That is asking for high dose.
He asked for high dose. He asked for high dose. Is there any rule for high dose corticosteroid for a critical case? What I understood from his questions, that he wants to give a mega dose of a steroid, and thinking that higher dose will give a better outcome.
Okay, I hope the answer is clear for you, Dr. Mahdi. Now, Dr. Srinath, there are 2 questions for you. The first question from Dr. Muhammad Uthman. He's asking, what is the best time to start acetylcysteine, N-acetylcysteine? Is it when SpO2 higher than 94 and patient has cough, or we should wait till SpO2 get lower?
N-acetylcysteine in COVID does not have any guideline recommendation as such at present, but people have been using it on an empirical basis because it is basically an antioxidant. And some people have said that in patients with COVID pneumonia, there is a lot of oxidant stress. So N-acetylcysteine can help. There is no actual guideline, but if you want, you can use it either in the nebulized form or in the oral or IV form. But there is no guideline recommendation for N-acetylcysteine at present. Maybe in future there might be, but at present there is no guideline recommendation, and I have not used it personally.
Okay. Second question for you, Dr. Srinath, from Dr. Osama Ibrahim. As you mentioned that type H meaning consolidation or ARDS. So is the management of oxygenation be different from that type?
Yeah, that's what I was trying to tell you. It is important to differentiate type L and type H in the sense that a patient with a type H phenotype will require more aggressive oxygenation right from the beginning. You cannot keep him on a nasal cannula or a face mask and hope that he gets better. This guy will most probably need NIV right from the beginning. And if the NIV is not going to help him, he's going to go for invasive mechanical ventilation. So the reason we want to type this is because you might have a lot of patients and you don't know which patient needs more attention. So the type H patient is always earmarked for a worse prognosis, so you have to pay more attention to him.
Okay. Dr. Ala, there is a question from my friend, Dr. Muwafaq Al-Fah. What would be the explanation for high ferritin in COVID? Has it been reported in other viral illnesses?
Ferritin is acute phase protein, and they found in COVID crisis that hyperferritinemia, when it is more than 400, is one of the findings in severe and critical case. And the higher the level of ferritin is associated with the higher mortality rate and more stay in the hospital. The hypothesis behind it is that this ferritin, as we know, it is a protein found in the liver and in the reticular endothelial system. And when there is infection with COVID, especially severe infection, there is overstimulation of the macrophage to produce more ferritin. This hyperferritinemia will induce the direct immune suppression and downregulation of the immune system and explain why the patient's condition is deteriorated. But is it specific only in COVID? No. Hyperferritinemia can be seen in other viral and can be seen in leukemia, can be seen in lymphoma, can be seen in diabetes, and can be seen also in those with iron overload. So it is not specific, but all the observational and retrospective analysis of the data, they found that all the patients who are admitted with a very high ferritin and further increasing the course of their disease is more severe and the mortality is higher. So whenever we have such cases with high ferritinemia, we should take care and should be closely monitored that this patient is at high risk for deterioration and for mortality.
Okay, thank you. Dr. Osama, one question. You mentioned CORAD from 1 to 5. So the CORAD 1 to 5 is the possibility of diagnosis, not the severity of disease. So you may get patient severe disease, but he CORAD 3. So the question clearly, the CORAD stage or grade, not related to the clinical condition of the patient, just the possibility of diagnosis.
Yes, actually, these CORAD systems like PIRADS of the breast cancer, like a lot of RADS of the prostate and liver, and like this. This is for the suspected diagnosis of the COVID-19, and because RT-PCR test, when taking time to the results appear, I think HRCT to classify the CORADs of the patient until the results of RT-PCR at least appear, it is good to classify them and make suspected. As you see in our cases, which I follow in, I presented in the presentations, the CORADS is almost appeared like the results of RT-PCR when CORADS 2, for example, can be appeared negative mostly, and the CORADS 4 and 5 most of cases appeared positive in the RT-PCR. So it helping also in the giving idea about the susceptibility of the disease more than the severity. Yes, it is not talking about severity at all, talking about the possibility only.
Possibility. Okay. Yes. Two questions for Dr. Ala and two questions for Dr. Sirina. Dr. Ala,
can I ask one question to Dr. Ala?
Yeah, Dr.
It is related to the previous questions, possibility and the severity of the disease. Also, the HRCT can make follow-up for the patient of the positive, and you can detect the prognosis, if it is good prognosis or bad prognosis. As Dr. Ala mentioned in his presentation, from the items to discharge the patient, significant improvement of the HRCT. And I want to ask him what is the meaning of course significant here? Is there in degree for the significant half of the abnormality on the chest X-ray, for example, or no significant only it is personally? Also, the other question in the same area. Sorry, Dr. Ali. Thank you for your informative presentations. It is highly informative and awesome also. The other issue, if the patient is not significantly improved, or HRCT of him is poor prognosis or more increased finding, and the patient RT-PCR is negative for a lot of one exam. What about your plan for that also? Thank you, Dr. Ali.
Yeah. In fact, for patients with COVID, the most important issue is the clinical condition of the patients. If the patient start to show improvement, and what we mean by improvement, that the oxygenation of the patient become normal on room air. Second, patient is the biomarkers all start to come down, and the CRP is coming down, the ferritin level and the troponin and the LDH and the liver enzymes all normalized, and the patients is feeling that he is improving. Also, this is important. So we have the patient issues and we have the physician issues to monitor the improvement of the case. But in case if that the patient is improving and clinically all the parameters normalized, the presence of residual HRCT is not that important because it would take longer time to disappear, and maybe the patient will end with some residual fibrosis. Like for example, patients with TB, patients may end with residual fibrosis, bronchiectasis, but the patient improved and become asymptomatic. So the clinical parameters is more important than the residual. But if you tell me that patient is having deterioration clinically and the HRCT is either the same or become worse, here is the problem. This means that the patient is going into the more high risk and more mortality.
Okay. Thank you, Dr. Ala. Dr. Ala and Dr. Sirinath, and please all the speaker, we can fastly answer the question because now almost we are passing more than 2.5 hours since the lecture. So Dr. Ala, fast answer. There is a one, and I think all the answers later on are clinical cases. So there is one question from anonymous attendee. If the patient have sign and symptom of COVID, but PCR negative on 2 occasions, 7 days apart. So the patient have a sign symptom, but PCR negative on 2 occasions, 7 days apart. But he is free from symptoms within 5 days. When can we stop home isolation? So why isolation? The PCR.
The patient,
you can answer. Yeah.
In fact, if there is two COVID screening, but should be properly collected, this is the most important thing, because if they are taking the nasopharyngeal swab, sometimes they can feel some resistance at the turbinate, and they will make the rotation of the swab at that place. This will give a negative result. In fact, when there is such resistance, they should try to move the straw in a way or another to push it till it reaches to touch the pharynx. Otherwise, the result will be false negative. But if it is properly collected for two results, and both of them are negative, and the patient is free from the symptoms, so no need for isolation.
Okay, thank you, Dr. Ala. Dr. Sarinath, what is your opinion about this clinical case? What's your opinion? This is a question from Dr. Batul Ala Amin. What's your opinion about what BC? She wrote to 1,300. I'm not sure if she means this number. And low lymphocyte in patients with COVID.
The patients with COVID, usually they have lymphopenia, leukopenia. So it is a part of the COVID phenomenon.
But that doesn't mean related to severity. Maybe it's mild, maybe moderate, and severe.
Yeah,
so this doesn't mean severity.
Yeah, it does mean severity. You have a neutrophil lymphocyte ratio, and some people where you're not able to do a differential count, you can take the total leukocyte count. If the total leukocyte count is very low, that can be a sign of severe viremia. It can mean that the patient is having severe viremia, which is a poor prognostic sign.
Okay, good. Dr. Ayman, there is one question for you. Do you think your action plan can be implemented and applicable in Mosul City? And fast answer, please.
Yeah, definitely. It is actually, and after we discuss it with many doctors who are practicing there, they said this is a practical and we can do it, but we need a collaboration between all the all the entities actually. ويعني يمكن اقولها بالعربي، احنا هاي المدينه كل ما تنكب يحتاج تعاضد بين اهلها وبين كافه القطاعات حتى يعني نقدر ننهض وان شاء الله نعبر الازمه باذن الله تعالى.
ان شاء الله. Dr. Ala, a question from Dr. Adana. Can catastrophic antiphospholipid syndrome be a cause in deterioration in severe cases? Is there a rule of hypercoagulable workup as anticardiolipine antibodies, given that some families get worse outcome than others? I think the question...
Patients with antiphospholipid syndrome, without COVID, they are at risk of both arterial and venous thrombosis. So in the presence of COVID, of course, the risk will be higher. And such patients should be on therapeutic dose of enoxaparin rather than prophylactic to reduce the risk of thrombopulmonary embolism.
Okay, good. So now the question for both Dr. Ayman and Dr. Sarinath. So Dr. Ayman, because you know the Mosul city very well, and Dr. Sarinath, because he knows the data, can we say that we enter the second stage of pandemic because of the increasing number of cases of COVID-19? So Dr. Ayman, if you can answer, then Dr. Sarinath, please.
Yeah, I think we are there, almost there, and I'm afraid we are going to the third stage actually. إن شاء الله we are not. اللي قاعد اشوفه انا من الديسشارج كثره الانبيشنتس as far as I asked our colleagues in the hospital, they said they are coming more and more it's increasing unfortunately.
Dr. Sarinath, what's your opinion? Sorry, you finished, Dr. Ayman?
No, that's it. Okay, go on.
Yeah, okay, Dr. Sarinath, what's your opinion?
Actually, right now, the European Respiratory Society, there is an ongoing conference, and there was a WHO epidemiologist who was asked the same question, that all the European countries, after they have opened the lockdown, the cases have started increasing again. So is it a second wave? So the WHO epidemiologist, she said that this is a surge and not a wave. The patients' cases were decreasing and they had gone to zero because of the lockdown, and then when the lockdown was opened, it means that the virus was still circulating in the community, and then again you have a surge of cases because of the opening up of the society. So they are saying that there is a difference between a wave and a surge, and what we are seeing now is just a surge and not a wave. So I think that answers your question, right? It is not a wave, it is a surge of the cases.
Yeah, that's true, doctor. And they are afraid from the winter because they don't know exactly what we are going to face, actually.
Exactly.
Yeah, so hopefully we will not see the worst.
More cases. Okay, Dr. Ala, fast answer. Another question from Batul. Two questions from Batul. Dr. Ala will answer the first question. Your opinion of use of steroid and anticoagulation in mild cases of COVID?
There is no place for using steroid and anticoagulation for mild COVID.
Good. Dr. Serinath, also question from Batul. For how long use anticoagulation in old age, improving his condition, but still inflammatory marker high? She means that old age man, his condition is improved, but still inflammatory marker are high. For how long you would use anticoagulation? And the patient is old age.
Okay, so to begin with, this patient was, say, a severe case who was requiring oxygen, and now he has improved to the stage where he is on room air, but still his inflammatory markers are high. Is that, if that is the question, you don't have to follow the inflammatory markers so closely. If the inflammatory markers are showing a decreasing trend, for example, you have a ferritin of 2000 on day 1, and then slowly when the patient is improving, the ferritin levels are decreasing, but they have not become normal. That itself is a good sign. So that means that the patient is improving. And some society are actually recommending that patients who are suffering from severe and critical COVID, after discharge, they should continue oral anticoagulation, novel oral anticoagulation, the Novax, for a period of time. So various societies are giving different recommendations. So usually you can give them for 2 weeks to 3 weeks after discharge. This is only for severe and critical. These are society guidelines, society recommendations, but you can quote the society when you're following it, but not for mild or moderate cases, only for patients who are suffering from severe and critical cases. If the inflammatory markers are showing a decreasing trend, it doesn't have to normalize. If it is decreasing and if the patient is clinically improving, that is a good sign that the patient is improved.
Good. Dr. Serinath, the last question for you, and we'll change to Dr. Ala. I will just answer and give you answer. So Dr. Serinath, please, fast answer. Why severity of symptoms of COVID-19 is different from country to other? Is there any answer for this question?
There are multiple hypotheses, but we don't know exactly. For example, in India, they are saying that the BCG vaccination, which is a mandatory vaccine in India, is helping people have a very low case fatality rate. I mean, though the number of patients are high, the case fatality rate is very low in India. And we don't know, maybe there is some genetic linkage, we don't know, we're not aware of it at present. Maybe in future with research studies, we will know.
Okay. Dr. Osama, the patient, sometimes he's COVID and he's hypoxic and he's not improving. Would you recommend to order CT angio pulmonary to rule out the pulmonary embolism, or you can ask to follow the CT chest, high resolution CT, to see the patient improving or deteriorating? I mean, for them, when you recommend to order CT pulmonary angio, particularly we know that these patients are at high risk of the pulmonary embolism.
Actually, this depends on the patient clinical status, laboratory finding of the dimer, and like this. If there are suspected embolism due to anything, also you can make Doppler for the lower limb if there are DVT or like this. All these findings raise the possibility of presence of embolus, so CT angio at that situation is recommended. However, actually, I'm not the one who requested the clinician knows the request according to the clinical and laboratory finding. For me, if according to the data in the HRCT, I classify them, and also I can follow the patient if there are good prognosis in the film or resolution or deterioration of the finding, and can told the clinicians to take notes about his patient is responding to medications or not.
Okay, thank you. Dr. Ala, maybe the last few questions, but you can answer it fastly. Actually, the question now from Dr. عبد الهادي الجميلي. دكتور عبد الهادي الجميلي هو اخصائي باطنيه مسؤول وحده العزل والحميات في مستشفى الشرقاط في محافظه صلاح الدين. He's asking multiple questions. Most of the questions you answered them, but he's asking about three main issues. The first of all, Dr. Abd al-Hadi, he's managing a lot of cases, so he's asking that he is going with more conservative rather than aggressive, giving antibiotic, giving drugs. So he's asking about, is there any strong evidence of this drug we are using now? And is there any benefit from honey, العسل, because he notes that all the patients he's giving them عسل, they are improving.
For you mean antiviral?
He mean antiviral, remdesivir,
antiviral,
and
yes,
this one.
Yes. There is so many good, well-designed, randomized control studies on the remdesivir, on the tocilizumab, and on favipiravir that show there is good outcomes in terms of stay in the hospital, in terms of reducing the mortality in patients, especially those with severe and critical mechanical ventilator. For those with moderate, also they found that, as I show you in the slides, that using also of favipiravir, it will enhance and accelerate the viral clearance and the stay in the hospital. So yes, there is a positive benefit for these drugs. But using hydroxychloroquine, chloroquine without azithromycin, using lopinavir, ritonavir, these are no more used and not approved. I mean, and they withdraw it since July 2020. So what remain is the convalescent plasma and the use of interferon. In fact, interferon is not used alone. It should be used in combination with the other antiviral drugs. It will give more synergistic additional effect. And there is two randomized control study done and showing the beneficial effect. But it should be used early, not late, when the patient deteriorated and become mechanical ventilator dependent. Yeah.
Okay. So
about the honey. In fact, there is no harm if the honey is original, not sugar.
From where we bring it? So we'll ask him to bring for us.
This is a million.
According to the price.
This is $1 million question. I heard there is one area in north of Nepal. Something really surprising. 1 kilo from this honey, $5,000 US.
Oh,
$5,000 US.
So what's the benefit? Why it is a honey or is a gold? This seems to be gold.
No, yes. It is more. It is better than. It is more expensive than the gold. You know.
Yeah.
Because it is. They are collecting it from mountains, and if you see how it is difficult to collect it, and how many type of flowers there. This honey is a cocktail from thousands of herbal flowers used there. So you are taking a real medicine.
Yeah, right.
دكتور يعني احنا alternatively عندنا عسل الشمال يعني north of Iraq honey is the best in this case.
ما هو the problem. They are feeding the bees now sugar.
صحيح.
So this is the problem. يعني
دكتور علاء
يعني
العفو اذا تسمح لي دكتور ثائر، يعني بمناسبه الحديث عن الاكل، صحيح دكتور الحليب ومشتقات اليوغورت and others is thickening the mucus ولهذا ما ينصحوها كثير في التريت يعني في اثناء التريتمنت او للكوفيد بوزيتيف patients وينصحون بالاونيون as a mucolytic.
There is no such. This is traditions. There is no relation between COVID and between taking milk and milk products at all. Okay. But if you ask me about the yogurt, yes, maybe because it increased the cough in the patient. It is irritated, not because it is contraindicated, but because like the citric fruits, it initiates more cough, but it is not contraindicated. It is not harmful to the patients. It is rich with vitamin C. And if you told me about the onion, yes, onion, if anyone can take onion, that is good. Yes, it will improve it will bolster the immune system. It will bolster the immune system, yes, yes.
Okay, thank you. The last question for Dr. Ayman, because you know all the protocols of Ministry of Health and the Prevention in UAE, and for Dr. Serinath. Actually, in Iraq, there is one doctor. He is claiming that xylocaine gel putting on the nostril can prevent the development of the COVID. So Dr. Wajih is asking, is there any role of xylocaine prophylaxis and treatment of COVID-19? Dr. Ayman and Dr. Serinath.
Well, Dr. Thair, I was checking this through a discussion. هو نفس الدكتور اللي يعني the same doctor who described this. He was defending himself with others, I think Indian specialists. The problem here, which is he is facing, and he can't defend himself, is that when you are using xylocaine locally, it might suppress the cough, and it's very dangerous, as you know. يعني while we are suppressing a productive cough in this case. Yeah. فكان يعني كان كلش غلط، وكان قرار وزارة الصحة يعني حقيقة صحيح في خاطئ يعني to be honest يعني.
Serinath, any sorry.
I have no, I've never heard of it.
Because you know in India and Iraq, they can use everything. You know, particularly in Iraq, there is no rules. Now they can do anything.
Dr. Not in Iraq. The President Trump, they said if the alcohol killed the virus by just hand washing in just 30 seconds. So why these companies not producing a similar alcohol antiseptic that can be pushed into the bronchial, and this will kill the virus there.
But Trump is not a doctor. But Trump is not a doctor. Trump is not a doctor.
He's a doctor. He's a doctor in all some specialties.
He can do anything. But in Iraq, there is now a lot of misunderstanding or misuse or mispractice or malpractice even to use xylocaine. Just put some xylocaine gel on the top of the nostrils, and this will prevent. I think this is rubbish and should not be allowed even to mention that. I think Dr. Serinath also agree that
some of them they are using hot water.
I totally agree with Dr. Thair. You're not supposed to use such things which don't have any evidence. You will promote other people also doing it.
Yeah, because the people now, if you tell them that this is a treatment, medical treatment, and this is a herbal or something, they will go to the herbal. They try to simplify. So it is our job at the end of this lecture. Is our job not only to treat the patients, also our job is to protect ourselves, to protect ourselves, to be safe, and to protect our families, and not to follow malpractice here or there, even if they are very famous on social media. Please just be adhere to the guidelines, adhere to the protocols. I think the protocols all over the world is the same, maybe changed according to the country and according to the population, according to the age, but please just adhere and try to focus on your patient and to follow the action plan done by Dr. Ayman and to follow the guidelines. It's very clear given by Dr. Ala and the ICU management and oxygen, because a lot of people asking me about this oxygen therapy. It's very well discussed by Dr. Serinath. Dr. Osama, very nice, very, very nice presentation. And he showed the X-ray and CT finding. At the end, I want to thank all of you. Be safe and try to be away from this infection. Actually, in Iraq, we lost a lot of our friends. I'm not sure what's the cause. but try not only to manage, also try to protect yourself. At the end, thank you very much. Thank you for all the speakers. Thank you for all the attendants, and special thank for my friend Dr. Wala Fathi Juburi. She is a consultant family medicine. She play a major role in distributing the invitation to all of our friends in Mosul city. Thank you, Dr. Ala. Thank you, Dr. Serena. Thank you, Dr. Osama. Thank you, Dr. Ayman. And thank you all of you.
الله يسلمك. وانا ايضا اريد اشكرك دكتور ثائر، وانوه على شيء. ان شاء الله هاي المحاضره راح تكون موجوده على مواقعنا، يعني احنا على الفيسبوك وكذلك على جروب دكتورز بيشنتس كمسجله، وايضا قسم من الاسئله اذا ما جاوبناها راح I will capture it حتى نجاوبها بعدين. حتى هناك اذا صارت تعليقات على جروب دكتورز بيشنتس بالضبط ممكن نجاوبها، ونجاوبها تفصيلا بعد ما نبعثها للمحاضرين الفضلاء. واشكرك دكتور ثائر على اختيارك لهؤلاء يعني الله تعالى
شكرا حضرتك.
الله يبارك فيكم جميعا. شكرا لكم تصبحنا. شكرا لكم تصبحون على خير. مع السلامه.
شكرا.
مع السلامه. مع السلامه.
Thank you very much. عليكم السلام ورحمة الله وبركاته.